so everyone can join.
No,
Yeah.
no problem. We'll wait. Thank you.
రామ్ కుమార్ మీరు ఎక్కడున్నారు?
గ్రీస్ లో మేడం.
అవునా, వచ్చారా? ఓకే.
సార్ నాకు నిన్నే తెలిసింది మీకు రాజాకు విసా కొంచెం డిలే అయింది అనేసి. కొంచెం లేట్ గా అప్లై చేశారా?
ఏంటండి? లేదు, ఫస్ట్ అప్లై చేసి we had to pull it out because urgent గా we had to go to Singapore. సో ప్రాసెస్ అయ్యే ముందు we had to take back our passports. దాని తర్వాత ఇప్పుడు మళ్ళీ సబ్మిట్ చేసినప్పటికి రాలే.
ఓకే ఓకే ఓకే.
ఎప్పటి వరకు ఉంటున్నారు మీరు?
నేను టిల్ 28th ఇక్కడ ఉంటాను మేడం. నాకు ఇక్కడ ఇంకొక డిస్ట్రిబ్యూటర్ తో మీటింగ్ ఉండదు 2 days. సో 29th ఎర్లీ మార్నింగ్ నాకు రిటర్న్ టు చెన్నై మేడం.
ఓకే ఓకే ఓకే, గ్రేట్.
మాకు రాజుదరే వచ్చి హీ అప్లైడ్ విసా పాస్ట్ 52 weeks బిఫోర్ ఓన్లీ. హీ ఆల్సో రిసీవ్డ్ దట్ విసా.
ఎవరండి?
R&D ఇంజనీర్ రాజుదరే అనేసి.
అవునవును,
మేము
అప్లై చేసాము. బట్ 1 week బిఫోర్ దిస్ ట్రావెల్ మేము వీ హ్యాడ్ టు గో టు సింగపూర్. సో మా పాస్పోర్ట్లు తీసేసుకున్నాం బిఫోర్ వీ కుడ్ డూ ఫింగర్ ప్రింటింగ్. సో వీ హ్యాడ్ టు రీస్టార్ట్ ద ఎంటైర్ ప్రాసెస్ అన్నమాట. వారంలో ఏది తత్కాలో విగ్రహాలు అన్ని ట్రై చేసాం కానీ అది అవ్వలేదు.
చెంగన్ విషయం ఆల్వేస్ ఇస్ వ్యాలిడ్ వన్. వన్స్ అది మీకు స్టాంప్ అయిందంటే పాస్పోర్ట్.
Hi sir.
Hi Raja, how are you?
நல்லா இருக்கேன் சார். எப்படி இருக்கீங்க?
நல்லா இருக்கேன். அந்த போட்டோ நான் ஆட்டு ஏஐல பண்ணதா? பயங்கரமா இருக்கு.
రాజా అంటాడు మాతో జాయిన్ అయ్యే ముందు అలా ఉండే ఇలా అయిపోయాను అని.
Sir, that is 3 years before, sir. The color of obviously even color to some extent, yes. But,
okay. No, really,
రామ్ గారు మీకు అర్థం అవట్లేదు. రాజా ఇండైరెక్ట్లీ నాకు కొడుతున్నాడు ఇక్కడ. 3 ఏళ్ళ నుంచి మళ్ళీ ఇలా అయిపోయాను అని.
అలా చెప్పలేదు సార్.
తమిళలో ఒక జోక్ ఉన్నది.
మైక్ చెక్ 1 2.
ఎప్పుడు ఎందనా నీ బ్రేక్ అనేది అది మరిగా.
మీరు కూడా కంటిన్యూస్ ట్రావెల్ లో ఉన్నారు కదండి.
మైక్ చెక్ 1 2.
బ్యాక్ టు బ్యాక్ ట్రావెల్స్ మేడం.
ఇప్పుడు మాది కూడా మేము ఇవాళ ఇన్ఫాక్ట్ రేపు మళ్ళీ సింగపూర్ వెళ్తున్నాం. సో మాకు ఇప్పుడు లిటరల్లీ ఇంట్లో ఏంటంటే సూట్ కేసు రెడీగానే వచ్చుతున్నారు.
ఓకే ఓకే. యాక్చువల్లీ దిస్ ఇస్ టైం మరి ఆప్షన్ లా మనకి కొంచెం దాంట్లో ఇట్లా ఉండిందంటే దెన్ వి కెన్ డూ ద బెస్ట్.
అదే తక్కిన తర్వాత ఒక
మైక్ చెక్ 1 2.
మీరు విల్లాలో ఉండట్లేదా రామ్ కుమార్?
లేదు మేడం, నేను యాక్చువల్లీ నాకు దర్ ఇస్ లిటిల్ మిస్కమ్యూనికేషన్. నేను వెన్యూ వచ్చి ఫస్ట్ వెన్యూ డిక్లేర్ చేశాను కదా, ఆ వెన్యూ పక్కన నేను తర్వాత డాక్టర్ గోయి వీళ్ళ పక్కనే బుక్ చేసుకున్నాము.
అవునా, ఓకే ఓకే.
తర్వాత ఈ విల్లా ఇది అన్ని చేంజ్ అయిన తర్వాత విల్లా ఇస్ ఆల్మోస్ట్ 60 kilometers, మోర్ దెన్ 60 kilometers ఫ్రమ్ దిస్ మెయిన్ సిటీ.
ఓ ఇస్ ఇట్? ఓకే ఓకే. అవునా, అది బీచ్ దగ్గర అంట కదా.
వన్ వే అండ్ అప్ అండ్ డౌన్ అంటే 5 hours అవుతుంది.
కష్టం అయితే.
ఓకే,
తక్కిన డిస్ట్రిబ్యూటర్స్ కలుస్తున్నారా అక్కడ? ఎలా ఉంది అక్కడ?
అవును మేడం, మనకి ఇక్కడ ఆల్రెడీ వీ హ్యావ్ 2 distributors హియర్, బట్ బోత్ ఆర్ నాట్ ఎట్ ఫైనలైజ్డ్. వీ హావ్ బ్యాక్ టు బ్యాక్ 1-to-1 మీటింగ్ అరేంజ్ చేస్తున్నాను.
అంటే వాళ్ళు అన్ని ఎక్విప్మెంట్ చేస్తారా, ఓన్లీ సర్జికల్?
ఒక్కరు వచ్చి ఆఫ్థాల్మాలజీ స్పెషాలిటీ చూస్తున్నారు, ఇంకొకరు వచ్చి ఆర్థోపెడిక్ అండ్ స్పైన్.
అవునా, అదెవరండి? ఆర్థోపెడిక్ స్పైన్ మా ఎంఆర్ఐ కావాలి.
నాకు మీకు సెపరేట్ గా పంపిస్తాను వాట్సాప్ లో ఆల్ డీటెయిల్స్.
సర్,
I'll just mention our MRI details also.
Done.
So let us first evaluate their caliber of how they do all these products, capital equipments and all. Then we'll go further.
Do you have WhatsApp in here? Is it connected? Okay, no, it's not. How can I get you the link here?
I don't know.
What email do you have? How do you connect? Do you have email?
No, this is my dad's laptop, bro.
We need to get the link here. You know what I
What am I supposed to do then?
Sorry. Doctor phone చేశారు ఇంకో 5 minutes లో స్టార్ట్ చేస్తున్నా.
I don't want to
ఏంటి
open this.
క్యాపిటల్ ఎక్విప్మెంట్స్ అంటే మనకు అక్కడ లోకల్స్ కావాలి
Can you
కదండి,
connect
మనం
to
సూట్
WhatsApp,
కేసుకు
yeah?
వెళ్ళి అమ్మడానికి అవ్వదు.
Yeah, come
So అందుకు
bring your WhatsApp.
But
Yeah,
yeah,
bring
yeah,
once
yeah,
you
yeah.
follow caliber
Bring your
AC, then we'll
Me-
connect with them.
మీరు చూడండి హౌ ఇస్ దట్ దెన్ ప్రాబబ్లీ ఎప్పుడు చూద్దాం.
Yeah, మీకు తర్వాత వాళ్ళ ప్రొఫైల్లో మీకు షేర్ చేస్తాను, మీరు చూడండి.
డన్. ఓకే.
ఓకే.
Dr. Afsar, can you hear me?
Yeah, I can hear you. Yeah. Do you hear me?
Yeah. So yes. Are you able to enter from Dr. Sherian's laptop?
I'm trying right now. I'm trying to get Suki
Okay.
to get online, but I don't. I'm not. Maybe I can do it now from her WhatsApp.
So yesterday he asked me to email it to him. I'm just going to do that again right now.
Yeah.
I don't know if you have access to his email.
Yeah, I don't want to open his email because he's not around. You know.
Okay.
But I think I will be able to do it. The connection is alright. Give me that.
I'm just trying to my friend real close.
This is your dad's, right? Can I have it?
Do you want something from us? Helping? Something?
At the moment, no. We were just waiting for the others to come fix them. Or if you could connect the Zoom here. Can you fetch the link onto this, or?
You need the link.
Try
from
the-
the
You have WhatsApp? Can you open WhatsApp?
I'm trying to do that right now.
Wait, what are Gmail?
Yeah, wanna send you the
Zoom link.
email?
Yeah, I sent it to his email.
Yeah, I have it.
I'm just gonna keep my phone here.
Open Zoom. Yes.
So, close mic, close camera.
Okay.
Perfect. And you only share a representation.
Share.
Share.
She'll tell you what to do. So this gets connected, right? And this is what you do. Yeah, I can
Is that?
But you need to behave though. Right? And then what you do is, you see this button? That's what you do is, you touch this.
Well, I know.
You know, okay. I'm just telling you. How should I do it? So this is it, like, I think you will use Rob's laptop for your
What about him?
first you can swing it. Do you have your PowerPoint open?
You probably have your microphone.
No.
I should mute it here perhaps, right?
Oh yeah.
No, it's not that.
It's coming from me.
No, we closed your microphone before, right?
No, but it's actually muted here.
It's muted here as well.
It's muted here. It's strange.
Να σου πω, κλείστε λίγο. Κλείστε λίγο. Από κάπου που έχει το κλείσω.
Could it be the mic?
No, our mics are here, and this is where they hear you from. One.
You need, no, I know what you should do. You should reduce the voice here. Here. But
Let me turn off the volume.
Yeah, maybe you should use it. Yeah. Yes, that's correct. Because you will actually be hearing from our speakers.
Okay.
You don't do anything.
Do you have any charge on the computer? Do you have any charge?
Should I go get the...
Awesome.
I don't even know how it looks.
The white one with the 2 USB 3s. The white rectangle one. This size one.
We connected it.
Mamu wants to have you for breakfast. Today, all 3 of them are regulated. I mean, we will come and when it is required.
I'll just go eat.
Huh?
I'll just go eat.
Sir, turning to like.
No, start off. Join the link. Please join the link.
It's already done.
And then ask Vikrant to start. If Vikrant is not there, you can.
How do we do? Do we have internet?
Yeah, there is internet here. You can ask them to connect you.
Can I ask you the internet Wi-Fi, please?
Yes.
A bit silent.
Afsale, ninde laptop at join chedavi.
Set up written already.
No. You stay there. I mean, Keki will come, and I'm going to stay with my kiddo here. I'll help her with her presentation.
Ναι. Πώς, όπως τελευταίο?
Ask them to start. Vikrant's to start, and then Juma, Federico, depending on what Ramya has got the list on.
Is there a certain way that you connect this, or do you just press it? Hard
You
enough.
just have to, so it is just,
Yeah, it's very easy.
it's a bit.
Rough.
Doesn't feel right when you have to use force.
Yeah. That is probably okay. There's just a safety.
No, this doesn't. This one. Yeah.
Charge?
Yeah, charge. Good.
So, again, close mic, close camera.
Yeah.
You have camera there, mic there, and close your speaker to just share your presentation, okay?
No thanks.
Any volume you have, yes.
So how do I talk?
Do you want to sit here?
Because
you talk from these microphones.
okay.
So
Can you hear us, guys? Can you hear us, Ramya?
do I connect which link?
The link? You need the link?
He sent you yesterday.
You can, you can.
Ramya, can you hear me?
WhatsApp group and then.
Yes, I can hear you.
Okay, great.
Shall we begin?
Yeah, so we are all here. You can start.
Okay. Let me just record. Record.
Recording in progress.
Hello everyone, good morning and good afternoon, depending on where you are. Welcome back to day 2 of the first WFNS Innovation Committee meeting. Today we will continue to disrupt as we did yesterday, and we will be exchanging ideas from within various fields, including neurosurgery, industry, engineering, and AI. So we'll start with Mr. Amol, COO of Time Medical, who will be talking about brain aneurysm screening MRI systems. Amol, sir? He was here.
Let me check, Ramya. Give me a minute, I'll check.
Yeah.
In the meantime, Ramya, can you tell me this program for today, who all are speaking when and...
Okay, after Mr. Amol, it was going to be Raja, sir.
Recording in progress.
Continuing with it, and then Mr. Ramkumar. And then we're waiting for Dr. Vikram.
Yeah.
Who said he'll be joining a little late.
Yeah.
And then hopefully after him, Dr. Afsal, Dr. Juma, Dr. Federico, and then around 4:30 p.m., Dr. Roberto.
Yeah.
So you had also mentioned Dr. Bill's friends. I'm not very
Okay,
sure about that.
Ramya, we will do.
Yes.
We will go with Federico as soon as Amol's presentation is done. We will go with Federico.
Okay.
And then later on.
Okay.
Okay.
Yes. Noted. And he's joining right now.
Yeah. Ramkumar is joined.
Yes.
Yes, doctor. I'm joined, doctor. Good morning, sir.
Good morning. Good morning.
And Mr. Amol has now joined as well.
Yes, please, Amol, start.
Good morning, guys. Good morning, doctor. Am I
Good
audible?
morning. Yes.
Yeah. Happy to share this particular presentation of Vega, which is a 5-minute of MRI screening machine, which is specially developed only to screen lot of talk, which is the requirement these days. The only reason which we develop this particular MRI machine is to have a screening MRI machine where which will help us to do the lot of screenings per day, around 50 to 60 scans, without having to incur a lot of cost on the buying MRI machine. So that was the reason. So the basic agenda of this particular machine was the hardware specifications which are developed for this machine is almost better than 1.5 Tesla, where the gradient strength and the RF channels are much more powerful than the 1.5 Teslas, and that is the reason it could perform very, very well in terms of talk screening, where MRA talk or talk is the sequence which we have optimized in a way that it could complete the scan within 5 minutes. Below 5 minutes, and in addition to that, there's an AI which we have implemented where it will help us to reduce the scan time by 50%. So this particular point of time, we can also complete this particular sequence, which is trees off within 3 minutes as well, and it will give you the same image quality as you can see mostly on the 1.5 Teslas or 3 Teslas. With this particular low field MRI machine, that was the agenda behind this particular machine, where you can have as I mentioned, multiple screenings per day without having to invest into higher superconducting MRI machine, right? Why brain aneurysm, right? So as you all are aware of this particular issue, right, where out of the
And give a little perspective of why we started this. There was a huge, essentially in India, what we observed that every 3 in 100, have incidences of brain aneurysm, and about 4 in every 100 have instances of brain stroke. So if you're roughly looking at about 5 in every 100, 20% of the population having an incident. So it became very imperative in the population screening perspective to get into a preventive, resource rather than subjective thing. Because I mean, of course, all of you are the surgeons. The incidences after rupture, the chance of survival, or I would say, a patient with no comorbidities is much lesser when it can be handled with preventive screening, and then the solution is performed. So the need for a better way of a solution by which we can enhance screening was needed in the market. So that is essentially why we started with this. So from the technicalities of how it all happened, and getting into general population from our subjectively from the equipment side, we needed to get a machine which was, apart from being a CT, which is radiation specific, you cannot use it for screening purposes. You cannot send the patient or the subscriber continuously into a CT. The only way they were doing is using a CT angio with a contrast, and not in all scenarios would a contrast be ideal if they had some other health issues, and also putting a patient through multiple radiation scans in a year was not prospective. So that's the reason we had to get an MR, which was equally fast enough, and which was at a low cost, and which can handle the load of having continuous screening. So this particular machine can handle up to about 60 screenings. Since it's heavily optimized, it can handle 60 screenings in a day itself. General MR would handle about 10 to 15. Different type of scans in a day, but this optimized MR essentially can handle up to 60 screenings in a day. So that was the main agenda or problem statement by which we started working, and this is the solution which we have. Essentially getting, and also this particular MR, the operational cost of the MR itself on a day-to-day operational cost itself comes to 1/5 the cost of a general 1.5 helium filled machines which you see in the market. And also which has the electricity dependency is also much lesser. And since this is more on a, it's a permanent magnet and it's an open magnet, so the whole claustrophobia issue when somebody comes, so generally it is like when they're in a critical stage of illness, they will not look for a comfort of whether it's a closed bore or is it a claustrophobia issues and all that. But when it comes to screening, it's the other way around. It is more like they definitely look for the ease of screening and also the comfort. So that is where this particular machine was designed, so that it is open and it enhances and it is more, what you say, user friendly for that perspective to undergo screening, and it is less than 4 minutes. So that was the whole idea of getting this solution into the market. Amal, you want to add something more?
Yeah. So as Svetlana was mentioning, so as it is completely based on the permanent magnet-based system, and then and it's open, with the wide open 120 centimeters left to right, and then up to down is about 45 centimeters. So having an open MRI as an option for a screening, a lot of patients will be more than happy to go for a screening. So that is the design agenda behind this particular system. That's why open would be the best option for a particular screening option which we are presenting right now, right? So normally CT angio will have the radiation, and the CT angio will have a radiation, and then it will be the most cost-effective solution in terms of the CT angio and the MRI top screening. So there will be almost 1/5 of the cost even for a screening purpose as well. these are the conventional options which we have of, for aneurysm screening, top MRI, CT angio, and DSA. So all this CT angio and DSA will be more costly, where you have to use contrast also. So many of the other patients would not be going ahead with the contrast. Here on top MRI, we do not have to have the contrast injected also. So that is where the benefit is coming over. So one is the sensitivity of the contrast, another one is the cost. So these are all the important factors which this particular MRI is adding up to, right? Rajesh, can you go next slide, please? Yeah. So this we discussed already, where it's an open MRI. You can comfortably go inside. Within 5 to 7 minutes, you come out. 2 minutes just for positioning, and within 5 minutes, you will get a scan. And as this is a MRI, you don't have to go ahead into radiation. So, and then immediately this particular machine will have a 3D images, and then with the AI function, you will get a complete reconstruction, and which can be sent it through a PACS or a radiology system, and then it can get a report as well. Next slide, please, Rajaji. Hello. Yeah. Yeah, as we mentioned, the capex and opex is about 30%. 95% of the patient will go through it, and then accessibility by 40% for the most of the patient. And because it's a completely based on the permanent magnet based system, where you do not have to have multiple cryogenic components, that's why it's only this one particular cabinet and the magnet, the system starts running. Next, please. Yeah. So as I was mentioning before as well, it's completely developed and designed to do the 3D top, 2D top, and hardware components are designed in a way to do multiple studies at a time, and the hardware components are almost better than 1.5 Tesla. That is where you could scan in a lesser time, and you could save a lot of time. You could save a lot of money onto the cost of the MRI machine here. Yeah. All right. Any questions on this, please?
Amol, I have some comments. Can you hear me?
Yeah.
I have some comments to make. Guys, can you hear me?
Yes.
Loud and clear, Doctor. Yeah.
All right. Can you guys see me as well? Because I'm working through a very different mic and AV system, so I can't see Zoom where it is. Can you?
We are able to hear you. We are able to see you, Doc. Yeah.
Right. So the thing is, for Vega, why we designed it in such a way is because, we've had many patients who's had aneurysms and who never made it. If you have an aneurysm and you bleed, 87.5% chances are that you are dead or you are in a coma. Only 12.5% of ruptured aneurysms go back to normal life. On the other hand, if you detect an aneurysm, there's only 1% mortality. This is only 1%. That's a massive, difference. 90% versus 1%. 90% death versus 1% death. Let it sink in for you. The next statistic you have to understand is 3 out of 100 people have aneurysms. 3 out of 100. 3.3 to be precise. So imagine what an impact it has in even a village with 15,000 people. 100 1,000 meaning 33 people have aneurysms, 15 meaning 33 into 15, 33 into 1.5. So that's the amount of aneurysms in a small village of just a small village of 15,000 people. That's the amount of aneurysms. And out of that, anybody who's bled will not go home 90% of the time. Anybody who's detected and operated, only 1% of them will be dead. So this is the most damning statistics of any time. So we decided, what can we do about it? Japan had a population screening which was very successful. I don't know of any other population screening in Europe or United States which has been successful. To some extent it has been, but not. And the reason why it is, as Svetlana said, when we don't have a disease, our comfort zone is way lower down. Our sensitivity to these issues are way lower down. So people think about radiation, people think about the time, people think about the cost, people think about claustrophobia. So we made a machine. I told, I want an open MR, I want no radiation, I want no contrast, and it should be done in 4.5 minutes. This was done. And then the problem was, how do you make it financially viable? For that, we had to, the usual MRI scans can do about 15 to 20. And you have to charge the patient in that particular way. So we made sure that 60 scans can be done, and the charge can be so low that it can be accommodated in most insurance programs. So literally the patient doesn't pay anything. So this is what we achieved at the moment. This is Vega, and I think it would be one of the most important innovations of this decade at least. And that is what time has done. And literally this MRI, if somebody installs in any part of the world, they can start screening patients above 40 who are hypertensives, and I'm sure they'll find a lot of aneurysms and a lot of lives can be saved. So this is what Amol was trying to explain, I guess. This is the neurosurgeon's perspective. Anybody has any questions, will be welcome to take it. Any questions? Nothing at all? Guys, can you hear me?
I was expecting a lot of questions.
Loud and clear, Doc, yeah.
A lot of things to think about.
Yeah, so any questions from anybody? Who's the next on talk, Ramya? Federico, right?
Federico? Yes.
Yeah, Federico, can you start your talk, please?
Absolutely.
Now, let me introduce Federico. Federico is an absolute disruptor. He's disrupted with education. Now, this is the most important tenet of neurosurgery. Why I say that is because, the neurosurgeon's progress is like a wave, but which stands the same place. Yasagil, he started that wave, he reached the zenith, and then everybody in the next 50 to 60 years, we have been learning, we have had experience, we reach the same heights, and then we don't pass it on to the next generation, because the next generation again has to go through the same rigorous things that we went through. Some of us make sure that they go through it because we are sadistic and egoistic. Some of us, although we want to make the education better, we cannot do it because we cannot find ways to do it. Now is the age of internet. Also the dangerous practices of people seeing YouTube videos and operating. But can we bring education to the lab, to skills, to models, And that's exactly what Federico has done. He took on this task, and from the models that you would laugh upon, he has made models that are really lifelike. I've had the good fortune to see them and use them in some of my courses, but they are amazing. And cadavers now are not very available. Some countries it is, but some countries it's not. And this gives an absolute chance for everybody to practice the skills and be much more equipped when they go to operating theatre. So thank you, Federico. It's an honor to have you here.
Thank you. Do you hear me? Okay. A bit closer.
Can everybody hear Federico?
Hello, do you hear me?
Yes.
Okay. So thank you for the nice introduction. It's a great pleasure to be here with you all in this incredible place. Thank you to Basileus that is hosting us. Great friends that I met here, new friends. It's very inspiring. You did a very nice introduction. I want to start saying that technology is just technology. Behind there are teams of inspiring and inspired people, and I feel inspired by you, by the way we are doing things. So today I share my experience. I have always two hats. I am a neurosurgeon, I am an entrepreneur, so sometimes someone gets disturbed by my double hat, but this is the reality. Unfortunately, I have two hats. So I will share with you my experience, trying to be very transparent in my conflict of interest, of course, and trying to clarify what we have done in terms of research. So what we do is, this is an example of a spine endoscopy procedure where we are going through the interlaminar space. We are trying to access the interlaminar space. We are trying to identify the end of the ligament and trying to access the intra-canal space to identify the herniation and so on. But this is not a real case. This is a simulation. I hear someone talking. Any question?
Vikrant, you are okay.
So this is a simulation, just to say, many people ask us, try to understand what do. We try to bring them the way to transfer knowledge, and the first thing is we need to replace cadavers. We are not trying to kill cadavers, I always say. We try to integrate. So what is the vision behind this kind of research? Is trying to bring our community to a future where we will be able to measure the abilities, measure the skills. And like in aviation, imagine being on a flight and the pilot says, "Good morning, thank you for choosing us. Today is a nice weather. Today the takeoff and landing will be operated by John, first day of residency. He has never done it. It's the first time. So enjoy. They will be traveling a little bit. Let's clap. You will obviously run away from this flight. This doesn't happen because we have simulation. So we have simulation-based certification. So any science is science, but somehow surgery, as you said, is still a mystic art. We need to transform this in a measurable science, and the way is to identify parameters and measure them, and possibly to start tracking and certifying the skills. So my provocative first sentence is, and generally I may provoke many defenders of cadavers, but we always say cadaver is the only way to train people, and I think this is absolutely not the case. And you are an example of it. You are a great master. You have done incredibly impactful courses with cadaveric dissection, but now we are trying to merge things. So we are not trying to replace anything, but just to merge. And what is happening is wider than this. We are talking about technology. We are talking about robotics. The point is, what about surgery in 10 years? It's so much complex than today, because we are now, a lot of technology that is coming together. So today we are training surgeons, but tomorrow we will train this concept of surgical intelligence, which is probably a human being in the middle. Probably still a human being in the middle. But there's a lot of technology around. So the training is train a person not just understanding the pathology but also using the technology in the correct way. So the surgical intelligence is a concept of human and non-human forces joining together. There is a lot of technology in the operating rooms, but the way we are transferring skills is not the same as the 19th century. Because a lot of technology, by the way, still you see, you practice if you have the chance. So the residents at the end of the residency, they will be completely different. Different masters, different skills. Some of them has been lucky enough to stay 6 months with Hyperion and seeing certain things in a certain way, but many others not. So at the end the curve is completely ruled out. Anyone is different. So anyone is really different. And we can say different disciplines, but we see how different disciplines proceed in a different way. For example, urology, they already use robotics, metrics, and we are thinking we are inventing something in neurosurgery that has already been invented in other disciplines. And the nice thing is they are neighbors. We are in the same hospital, same floor, different departments, and we don't even know what is happening on the other side. We should explore the other disciplines to avoid to reinvent the wheel same time. So the neurosurgery, this new awareness, now the residency is changing and we are moving from circumstantial practice to intentional practice, meaning I decide you, first year residency, you need to operate 10 tumors of this feature, with these features. So, or I have 10 patients to, let me say, sacrifice to the noble goal of training this person. Or you use 10 very good simulators trying to pre-experience you. Then of course you need the patient and you need to practice in the real world. You know, when my child came to life, the first child, sorry for this parenthesis, personal parenthesis, but it's a story. The doctor says, the nurse says, doctor, come in, you are a surgeon, come in. And I was very stressed. I said, I was white with this wall. Why? Because my child was coming, my first child was coming to life. And the second reason was that with the surgeon there was a first year resident on the table, and that was my wife. So I was stressed because that was, you know, the tradition. We need to learn somehow. We need to change this paradigm. We just need to see how we learn all the rest. How do we learn music or sport? Is by repetition. We just need to do repetition, and this is not something. This is already very well known in the literature. And we are just trying now to mix simulation and practice in the OR, so that is the concept. This is my field, I come from skull base as well, and this is where I started my residency and my practice in the first years. This is a dissection of a Sylvian fissure, nothing special. Yesterday Hyperion showed to me and the team few dissections. I have never seen anything like that. He enjoys risk in a way that I've never seen before. But you know, to do these things, you need to have natural skills, not natural skills. You need to train a lot, probably some natural skill, but you need to train a lot. The same situation after an hemorrhage, you are trying to train someone on, you know, vascular neurosurgery. We are dissecting now an aneurysm. We are trying to expose the neck of an aneurysm, and suddenly what happens is this: you may have a rupture. You may be lost in seconds, you may lose a life in seconds. So how do we train people with this situation? This is very, very difficult. So now this discipline is risking to die very soon. So we can say, oh, I made a mistake, I will try again with the next patient. But imagine translating this in aviation. This is impossible because after a crash accident, no one can come back and see what happened. So we need to think in the same way. It's avoidable, we need to avoid the accident. So what do we need to train people? We need three things: mental manual and mentorship, meaning we need mentors. We absolutely need mentors. There's no need to think that the technology can replace a mentor, because surgery is about being brave sometimes. So AI cannot teach me to be brave. Hyperion can be there with his nice voice teaching me very calmly, okay, do this, do that. And I start understanding how to manage myself and my feelings during that complication. The world is changing. I want to mention two big changes. One is accessibility. We see people on the stage operating today thanks to simulation. And the other thing is we started measuring things. In any discipline, in anything from cars to anything else, we are starting measuring. So the technology allows you to measure everything. So we want to measure also surgery. And the day someone will be able to identify metrics on this, will change many different, I say markets, but many big fields like healthcare, medical devices, and of course insurance companies that need to quantify the risk. So the data stream is important. We need to work on a data stream to measure things. But you know, in AI there is this new trend of measuring data from data from the operating room. So we take a lot of videos and we say, AI, please identify a trend. But there is a big bias, which is the inter-individual difference and the different cases. So there are so many different cases, and it's like trying to measure pilots in a different race. So we need the same car, same condition, and same ground to understand who is the best one. Simulation gives you this opportunity. Same problem, same complication, same case, different surgeon. Or same surgeon after 1 year of training, what happens? Data stream can come from the operating room, but also from pre-operating rooms where we can create simulation labs where people start training and measuring and understanding these things. As I said, this kind of stream and sequence of technology is evolving in different fields, and sooner or later we will start connecting the dots. We talk about robotics, we talk about motion capture, we talk about simulation, but we need to connect all these elements in a single sequence.
I think we lost you there. I think it's gone on mute. We can't hear you.
You can't hear us?
Svetlana, do you hear us?
Do you hear us now?
Yes, Doc. Now can.
Okay.
They don't hear us?
Yeah, they can hear us.
Okay. So the world is changing in different fields. There's no reason to think that this is not going to happen in surgery. So how do we imagine this kind of training in the future? The way is to copy a precedent which changes the world, which is the aviation precedent. So to do this, we are trying to connect different companies, different researchers, different visionaries, all together to try to understand what is the direction. And just forget that I am part of a company. It's not about the company. The company can die tomorrow. It's about a new culture, okay? And this is to tell the story about also, the work is changing. I saw residents recently saying, oh, it's 4 p.m., I need to go home. Because now the rules, the culture is changing. So we need to adapt to a new culture, new generations of people. And what's next? This is the big question. We need to imagine the future not to be passive. We need to imagine a future to do it, to transform it. And this is exactly what you are trying to do with these many webinars that we do about technology, trying to predict the future to do it, not to just wait that someone else do it. And many times, companies don't understand surgery. They create solution in search of problems. And that's why it's beautiful for me, this is my personal perspective, that surgeons guide the R&D behind the technology. Because they have the problem, first person, and they understand what could be the solution. Then technically we need the incredible engineers and etc. So we are trying now to use generative AI as well. We are accelerating very much our rate of innovation in simulation and training. So UpSurgeon basically does three things: virtual reality, physical. Is a group of surgeons based in Italy, the center, but many surgeons around the globe connected with us, and we try to invent things. We try to predict the next big wave, the next big technology, and we are working with a big community around the globe. The group is creating many opportunities around the globe. So the numbers are incredible in terms of how many people is working with us around the globe. And in 2021 we started also with free of charge courses in low and middle income countries. So we have done, as a private company, 45 free of charge courses in low and middle income countries in the first 3 years of activities, and these activities keep running, and it's very interesting. Simulation in this case, an example of these are nice toys. So Harvard made an incredible study a couple of years ago, a few years ago, about an example on vascular, and I share with you an example on spine. So Harvard and Stanford did this incredible study where we tried to measure the abilities during an anterior cervical dissection, and we needed to measure also the impact in terms of emotions. And in this case, on the right, there is a resident trying to perform the anterior access. But to do this in a successful way, we needed the full experience. So we needed carotid pulsating under my finger and understanding where the carotid is and lateralizing the carotid. And for the first time in the history, we see a tissue pulsating as in real life. So we already surpassed cadavers many, many times with pathology, with living tissues, etc. How do we do this? We are neurosurgeons, but we are trying to do this in a formula that we can scale up in all the disciplines. So with the methodology joining together with surgeons from other disciplines, we created a digital archive of anatomy and physical archive of tissues, and then we mix things and we scale up disciplines. So we are now in cranial, in spine, in maxillofacial, in ENT, in orthopedics, in plastic surgery, and this year we are entering endovascular and orthopedics in terms of shoulder and knee. So we are scaling up thanks to the community, and the community is also challenging itself because people want to do massive courses. This is an example of a massive course of a Zuba with endoscopy. They did an incredible thing. 50 stations, 100 people in 2 days, 300 surgical procedure simulators in 2 single days in a random room in a university. And this was a massive exposure to surgery, to experience, to errors. A lot of trainees came around. The goal was, endoscopy, and you see all these people in a row operating. And this is very, very culturally impactful. You see all these people without gloves operating all in a row, changing or learning from each other. He's operating. I just talk to him and say, oh, look at this, let's do it in this way. And we are doing an incredible community experience. It's not just we can change the simulator on the table. I'm not advertising the simulator. I am talking about the cultural experience, and people now want to do simulation courses independently by this specific simulator. This is another nice example. Tell me how to train people in pediatric neurosurgery. There's no other way than simulators, and this is a nice course. And the nice thing is, trainees in this case were experienced people, 50 years old people, not trainees, not residents. Why? Because many of them wanted to enter a new discipline, and the only way was to use lifelike simulations for pediatric craniosynostosis, as in this case. So how can you do this without a simulation? And now many approach the new discipline thanks to simulation. So maxillofacial and neurosurgeon during this course, I say this miracle. I do other example of massive craniotomy courses during the AANS. This is a nice picture at the end. Each one of these was an exercise. And this is another interesting story. If simulation can go beyond and bring you to pre-simulate crazy cases where the most experienced surgeon is a trainee, no? Because this is the first time they do it. This is a real case we did in Milan. 2 children from Africa with a foundation came to Italy. This has been just published, so this is real, just published on the literature. And we created the avatar patient, meaning these 2 children to be separated. We did something like almost 30 surgeries, 30 surgeries, but just 4 in the real life. So the rest were simulated surgeries on avatar patients. So we created these virtual and physical avatar patients, and the surgeons changed the strategy so many times, so many different ways. This is American and Italian surgeons working together on the case, and these are a few clips of the research on the physical and on the digital, and several. So we need to do a workflow in the digital and the physical. And this is the example of the embryonic process of creating the real anatomy of the children to be operated. We are not talking about 3D printed models. These are not 3D printed. These are operable soft tissues that mimics the real life tissues and can be operated in the same way with the same tissue of real life experience. So it's not 3D printed. It's a 5D printing technology, which is a completely different thing. And the result is this beautiful mom and the daughter were looking at each other in a very different pose, because first this was not possible before. And performance analysis, I conclude my presentation saying, okay, what about the future? Simulators have to talk. Today we do stupid simulators, they don't say anything. We need to do smart simulators able to say things. I'm telling you what you are doing during the surgery. And this is an example I want to show you. This real example of a big prototype we did on cranial surgery is a prototype, not still diffused. So I connect a physical simulator with an organic-like environment to an iPad, and then I do my training. And during this, everything happens in an iPad, and I start measuring pressures, stress on the several areas, stress on the optic nerve. This was an aneurysm clipping exercise, and I'm measuring everything. What is the goal? We wanted to see if these systems were able to distinguish, let's say, residents with few years of experience from a 10 years experienced vascular surgeon. And we did a study. We took two population, experts and novices, and the system measured them in different exercises. This is an example of the setting of the study. So with camera, with the motion tracking, and this analysis of AI trying to understand what's going on in the meantime. And the result, I always say, was the first step on the moon, because the result was that this already first prototype was able to distinguish in a so clear way experts from non-experts. But let's say two different populations, and we started measuring the non-experts. And in the non-expert, the system started saying, this is the best resident, and this is the last one in the classification. Okay, let's change exercise. And the system kept identifying still the best and still the last. So it was consistent. So we said, okay, we are discovering something interesting. Technology is trying to recognize you. So one day, our residents will be able to recognize themselves in curves. And we did it. We did another kind of course on spine, was very interesting. You see, the deformity simulator. So we are in the orthopedic stage. So people operating in a deformity, a very different, obviously, topic. I mean, very different from brain surgery, but just to let you know, I mean, to understand the difference, you see there is an app behind measuring how do I correct the curve, and so that is very important. So a system able to correct the curve, and then we started connecting all the stations to a screen, a big screen, with the classification. And you see here, there's people operating, and here there are all parameters, and there is the first one was the master, was the best one, and the others. And the people started moving their looks, their eyes from the simulator and progressively to the screen. And at the end, it was interesting to see people, instead of operating, like looking at the screen and say, oh, they are going faster, let's go better, they are correcting more. They were in a competition, very gamification. Surgery is not competition, but just to say, they started training to do the race. This is a race to quality, this is a race to excellence, not to gain over another surgeon always. And what does the technology? I am measuring the correction, and there is a digital twin that in real time tells me how do I rotate, the percentage of correction, or in terms of curve, in terms of the rotation. It's just an example. This is my last slide. The next frontier is intelligence, is extraction of data. We need data, we need to connect the dots, we need to reinvent them, and we need to create a community around this new concept, which is not just simulation, it's not just robotics, it's not just the human being a phenomenon, it's all these things together. Thank you so much. I hope this is my team. It's a small part of the team because there are many people remote, so we are around 70 around the globe. At some point with AI we put Optimus Prime behind, and there is a message that is generally, when the team is inspired and all together, the power is higher than the sum of the singles, and the power behind is represented by Optimus Prime, which is the metaphor of the union of inspired people all together. Thank you.
Thank you very much. Excellent. Excellent talk,
Thank you.
Federico. I see that Cadaver Labs in the next few years will be,
Champ.
cited in history.
Champ.
Yeah. But I would keep challenging you because with the exoscope we go into the ultra micro neurosurgery in cadaver. So for example, we sometimes do courses just on the sixth nerve, and it's so interesting to see the course of sixth nerve in the orbit, the course of the sixth nerve within the cavernous sinus, how the sixth nerve changes course. And to do that in models, I see that it's possible for you now. But for that, we should scan and we should get each cranial nerves into this system. Each vessel, small vessel into this system. And then start the simulation. So to the highest level, with what you have done, it's definitely possible. And I definitely was one of those people who would not agree for a model or a model course. I would always say earlier in my life I have seen a lot of models which is for drilling and which is for dissection. But after seeing your models, I believe that it's possible that cadavers may be relegated to history. So amazing,
thank you.
Really great work. Thank you very much for being with us. Yeah.
I think this craniopagus which you showed.
Sorry?
The model of craniopagus. That model is extremely vital. In view of this technology, you must have heard of the Iranian sisters who were operated by a team of people, and Majid Sami, obviously being an Iranian, he was the first one to be approached, and he entirely refused that such a possibility will not, it's not possible. Yet some people went ahead and did the operation, and you know the result.
Yeah.
First, one girl died almost on the table, and the other girl died a little later. And both of them, when actually it would have been possible to at least survive one person. See, if you had this technology, you could have studied all the effects, and whether to operate or not to operate is the first question.
Yes.
Sometimes we have to say no. We must learn to say no if it is going to harm the patient.
Yes.
It's a very important learning.
Yes. It's an interesting point. I have seen the surgeons for this surgery changing strategy. In particular, I remember the plastic surgeons.
Yes.
You know, plastic surgeons need to take care of the expansion of the skin for the closures. That was the most simulated stage. It was interesting because there's no many different strategies for the separation, but there were so many different strategies for the positioning of the expanders under the skin to avoid the cubitus. Okay, so damaging the skin, having infections, and they changed so many times the position of the expanders for the following months. This is just an example because you would say that is the simplest part. But they simulated many times, and that part could destroy the entire.
One wrong step.
Yes.
And
yes.
It's over.
Yes. So any aspect that's been prevented or let's say studied better, then of course you cannot predict everything, but it's better than zero. I always say it's better than nothing. When he was saying about the small vessels, etc., I have seen residents during courses killing the cadaver, honestly, again, because they were like not handling the scalpel properly. You do incredible things, but there are residents, 50-year residents, that don't handle correctly a dissector. So do we need to waste the cadaver for that? We can do a first step to prevent this kind of, first base, and then we go to the incredible deep things that you may do, obviously.
Of course, they have to start with basic anatomy.
And of course.
Even before you go on to virtual reality.
Yes.
They must understand basic anatomy.
Yes.
It has to start from the cadaver lab. Then go to VR and come back to that.
Yes. Yes. Thank you.
Yeah, thank you, Federico.
Thank you.
Very, very honored, and I'm very impressed. It's very rarely that I do get very impressed, but very impressed.
Thank you.
Now, so again we are disrupting, keeping on disrupting. I would want the cameraman to show us all around for once. So you understand, yeah. So you understand what is the concept of it. That is Bill, KT, and that's the pool side. And this is the concept of Villa Congress. A Villa Congress, where skill, innovation, and brotherhood. I mean, don't take me sexist. I'm not taking sisterhood because, of course, that's important too.
We have a sister here.
Yeah, we have a sister here too. So, yeah, so yes, this is what is important. So I think in the future, big venues, as I said, cold statistics, egos, this is not going to be introduced. What advanced science would be this kind of discussions. Villa Congress, I think I'm looking forward to more of these. Thank you very much, Bill.
You're welcome.
The whole
You're
credit
welcome.
goes to you.
I'm with friends, so I'm very happy also that you're here.
You don't realize you have created history. You have created history. Yes, without realizing it.
Now I'll call upon Dr. Vikrant Pujari, my respected colleague at University, Sevastopol Hospital. It's an approach through which you can approach the entire anterolateral window through just an eyebrow incision. So it involves suprabrow, transorbital, transcavernous, and endonasal windows. So multi-perspective, and so Vikrant will show you some slides and the dissections, as well as he'll also maybe talk about the lab. Vikrant? We want to have upsurgeon in the lab. That would make it more complete.
Whenever you want.
We would invite Federico to come there as well. So and see and tell us suggestions, and I would very much like to collaborate with Federico. It's an honor to have him here. It's truly a disruptor.
No, it's my honor to be.
Okay, Vikrant, you can carry on, please.
I would like to say one thing, sorry.
Yes, thanks, Ayub, and dear friends.
Hi,
I
Vikrant.
hope I am sharing my screen. Screen is being sharing over there.
Can you show Bill, please? Can you show Bill?
Come.
Hello, Vikrant, can you hear me?
Yeah. Can you see my screen over there?
Yes.
Yeah, Vikrant, can you hear Bill?
Can you hear me?
Yes, I can hear you, and you can see me as well as my screen is being shared with you.
Yeah, it's everything is absolutely perfect. I just want to say that for sure next time Dr. Vikrant will be with us here physically. He's one of the very good friend of ours.
I agree.
It is a great loss that we don't have him today here, but next time he will be physical also with us in this disruptive villa.
Yeah.
Okay.
My dear friend Ayatip and Dr. Turel and everyone over there, my best regards and thanks for giving me this opportunity. So I would like to start with my topic. Should I?
Yes, please. Yes.
Yeah. So the mosaic approach, as it is a multiportal or a orbital suprabrow approach, anterolaterally integrated corridors, the never single incision multiportal strategy for the anterolateral skull base.
Vikrant, you need to share your
Anterolateral
screen.
skull base, as you know, represent one of the most challenging surgical territories in one of the neurosurgery. Bounded anteriorly by planal spinoidally, laterally by the cavernous sinus and the Michel's scale posteriorly by the pituitary junction, and superiorly by the anterocranial fossa floor. This region is traversed by critical neurovascular structures, including internal carotid artery,
You must share the
optic
screen.
apparatus.
Vikrant, you must share the screen. Share this. You share the screen, please, so that we can't see your presentation.
Okay, 1 second.
Start again.
Yeah. Yes. Full. Yes. Excellent.
He's muted.
It's muted.
Yeah, you are muted now, Vikrant. You are muted. You can take your muting off, please. Can you be unmuted? Ramya, can he be unmuted, please?
You are muted.
Vikrant, you please unmute yourself.
Yeah, can you hear me now?
Yes.
Sorry guys, and so I should start now.
Yes.
The mosaic approach. It's a multiportal or vital supra anterolateral integrated corridor approach. A single incision multiportal strategy for the anterolateral skull base. As you know, anterolateral skull base represents one of the most challenging surgical territories in all of the neurosurgery. Bounded anteriorly by the plantar stenoid, laterally by the cavernous sinus and Meckel cave posteriorly, by the petroclavian junction, and superiorly by the anteroclavian subfloor. This region is traversed by critical neurovascular structures including IC, the optic apparatus, oculomotor and tracheal nerves, and the superior orbital fissure contents. The lesion assessed in the lesion, as you know, are paraclinoid ophthalmic segment aneurysm, anteroclinoid process meningiomas, cavernous sinus tumors, Meckel's cave lesion, pituitary tumors, and lateral extension tumors with upper petroclavian meningiomas as well. These lesions demand surgical approaches that can achieve wide exposure while minimizing the neurovascular manipulation. What is mosaic? Mosaic is multiportal, 3 distinct corridors working in concert. That's M. O for orbital. The orbit serves as the central unifying anatomical landmark. S is the suprabrow. The suprabrow peritomy provides the superior perineal support. A is the anterolateral, the primary anatomical target territory. I integrated. The corridors share a single incision and coordinated operating plan. C is the corridor. Each port is defined anatomical corridor with distinct reach. Now let's dive into this a little bit anatomy. I will start with this skull base image where you can see the optic canal with the optic nerve, anteroclinoid process. You can see the ACP here. You can see the foramen rotundum with the V2, foramen oval with the V3, foramen spinal with the middle meningeal artery, foramen lacerum where the IC traverses, just doesn't pass, it traverses curve over there. The jugular foramen is the jugular content, 9th and 11th cranial nerve. Then you can have jugular bulb over there, and you can see the internal acoustic meatus where IC is the internal acoustic meatus with 7th canal here with the hypoglossal nerve, foramen magnum, clivus here. So we're not going into deep with the cavernous sinus structures. Straight away going into this is a picture where you have the intradural picture here. Again, the same anatomy will go on. This is the optic. IC here, the lateral edge, you can see the third nerve, you can see the fourth nerve, you can see the fifth nerve, you can see. So dura is being removed, you can see the optic, IC, control edge, you can see the third nerve, ocular, fourth nerve, V1, V2, V3, foramen, rotundum, oval, and you can see the foramen spinosus as well here. This is superior orbital fissure with the V1, foramen rotundum, foramen oval, and foramen spinal. You can see the GSPN here. So just we are hovering in the posterior cranial fossa and seeing anterior toward the clivus, you can see the optic nerve, the IC here, the third nerve, fourth nerve, and this is the sixth nerve. This ligament is called as Hubert's ligament, that is spinoidal ligament, and you can see the V1, V2, V3 here. Same images. And this here we can see one of the beautiful images where we can see the olfactory optic IC here, proximal and distal dural ring, third nerve, fourth nerve has a lot of force, and it can just see, you can see it is going lateral and posterior towards the brainstem. This is the fifth nerve, V1, V2, V3. V1 is going to superior orbital fissure. Then you can see the facial hiatus here where the facial, there is the GSPR just above the C2 segment of the carotid where we have removed this bone of the vitreous apex, and you can see its anatomical landmark where the GSPN is located, and it just go below the V3. Foramen spinism. This is the just another rectified view. You can again we will just go to optic IC here, proximal distal dural ring. This is the third nerve, fourth nerve, V1, V2, V3. This is the Gubert's ligament. This is the IC. This is a GSPN. You can see. So coming down with a very close and zoomed view, we can the third, fourth, this is sixth, which is this is the petrosphenoidal ligament. You can see the sixth nerve is going below it. Okay, this is a GSPN which is above the C2 segment of the carotid. Anybody can tell me which is this ligament? This is pictolingual ligament. So we are very interesting the vasculature, not going much into the anatomy. Now let's discuss about this mosaic surgical procedure. This is a single incision eyebrow incision procedure, the master incision, which is a curvilinear incision over the eyebrow around 5 to 6 centimeters, and this incision is shared by both folds, that suprabrow craniotomy and both to transorbital lateral orbitotomy, rendering it as the master incision to mosaic approach. The superficial temporal artery is preserved wherever possible. Dissection proceeds through the subcutaneous layer and galeal posterior periosteal flap is elevated superiorly as a single layer to expose the supraorbital rim. The lateral orbital rim and the front span. The supraorbital neurovascular bundle is preserved within the notch. The periorbital identified the orbital rim and gently elevated off. The orbital roof and lateral orbital wall is exposing the cranial and orbital bone windows. This is very important step where you see the suprabrow craniotomy. A single borehole is placed at the keyhole point. The junction of the frontal squamous and sphenoidal bobbing and the temporal squamous 1 centimeter above and behind the orbital rim using a high-speed drill. 2.5 to 3 centimeter centrally located mid-pupillary line. Small craniotomy is done with the inferior margin at the level of the orbital roof. The orbital roof is included in the craniotomy inferiorly, thinning of the supraorbital bar without formal orbital roof removal unless the subfrontal forward requires it. There are various osteotomy procedures, but we are discussing here the suprabrow approach or mosaic approach, where we just remove the lateral orbital ray as well as supraorbital ray, or with the roof of the orbit and the lateral part of the orbit in a single incision. The device is opening in the patient best towards the orbital root. Sylvian fissure is open from sharp and blunt dissection to raise CSF and relax the frontal lobe. The subfrontal dissection proceeds along the olfactory tract to the optic nerve and child with ipsilateral optic nerve as a principal medial landmark. The carotid system is open sharply to expose the supraclavicular ICA. For paraclavicular pathology like intradural antisplenectomy is performed using a high-speed diamond drill under PPS irrigation, removing the glenoid from lateral to medial, detaching the falciform ligament and the distal trim to achieve the proximal ICA control for the Athens dissection. These are the various systems: Sylvian, carotid, laminar terminalis, system, interpedicular system. As you know, various triangle, carotid oculometer, and you can see this in these triangles where ICA and basilar teeth can be visualized. These are the ports where which can be visualized. This suprabrow oculus, these triangles can be visualized. And just retracting the third nerve, give access to the basilar teeth. That you just press the PCA medially, you will be going towards the basilar. The transorbital lateral orbitum is the next step. That is lateral orbitum. From the same eyebrow incision, the lateral orbitum ring is exposed using the oscillating from the lateral orbitum through the orbital ring into the lateral orbital wall, removing the lateral orbital wall back to the superior orbital fissure. This is very important. See, we are bending the root and going laterally and removing the lateral wall of the orbit as well towards the superior orbital fissure. The bone segment is plated for lateral for the lateral placement. The periorbital is reflected medially with the malleable retractor. Don't need to retract too much as the orbital globe patterns are there. The globe need not to be subluxed. This creates a wide window onto the lateral orbital apex, the superior orbital fissure, and the anterior middle cranial fossa. Then comes the extradural middle cranial fossa dissection, where working extradurally along the floor of the middle cranial fossa, the middle medial is cut and divided at the foramen spinal. The greater superficial petrosal nerve is identified as the middle limit of the extradural dissection. Dura propria of the cavernous sinus, lateral wall is elevated medially, exposing ganglia within the mical stair to the dural floor. V2 and V3. For the lateral cavernous sinus tumors, the lateral wall pleura is open between cranial and third and fourth superiorly and B1 inferiorly. Intradural dissection, when intradural access is required for cavernous sinus meningioma with cerebral fold and extension, or for the access to the intermittent endocrine system and posterior clinard, the dura of the posterior fossa is open posterolateral to the Meckel scale. This provides access to the anterior petrosal vein complex, superior petrosal sinus, which may be divided if required, and the anterolateral pontine surface. In this configuration, 4-2 effectively mimics the retrolabyrinthine 3-6 mode approach without mastectomy, exploiting the superior orbital tissue angle to reach the posterior fossa. Now comes the third part, that's endonasal pore, that's the endonasal approach, the third tiles. 1, 2, and 3, supraorbital, lateral, and now this endonasal pore, the third part. The endonasal component is performed simultaneously or subsequently with the cranial pores, depending on the operative plan viable instrumentation. The binocular 400 endoscopic technique is used with 0 degree and 30 degree rate for the endoscope. Ipsilateral middle turbinectomy and wide splenectomy are performed. The cellular flow for opticoparotid access and the middle cavernous sinus wall are defined using neuronavigation. Bimanual mosaic technique involves a full 3-4 mosaic configuration. The bimanual coordinated technique is employed. The surgeon operates to the port 1 and 2, while the second surgeon by the same surgeon system addresses the port 3. Intraoperative communication and coordinated neuronavigation prevents instrument conflict. The endonasal endoscope can be used as a visual portal while cranial surgeon operates affording a simultaneous complementary view termed as the mosaic view that allows real-time verification of the extent of the resection or androgen placement from 2 or more perspectives. One of the advantages of mosaic approach is a single incision dural port access. Perhaps the most architecturally elegant feature of the mosaic approach is the use of the single aerospace incision to deploy 2 distinct surgical ports, suprabrow and transorbital. This reduces wound-related complications, eliminates the need for a separate temporal incision or skull flap, and dramatically improves the prognosis. Elimination of temporal muscle manipulation, orthogonal complementary views. The anatomical triangulation offered by 3 near orthogonal corridors means that a blind spot of any single corridors are precisely the areas most directly visualized by the anesthetist. Bone preservation and replacement can be done, and there is very minimal retraction of the brain. Limitations and of course some potential pitfalls are there, like learning curve, orbital morbidity, CSF leak at the end of the cord, intervertebral lesions can be addressed but with little difficulty. Vascular injuries during the 4-2 and extradural dissection. To conclude, by integrating the supraorbital craniotomy, transorbital lateral orbitotomy, and endoscopic endonasal approach to a shared type of incision and a coordinated operative philosophy, the mosaic approach achieves comprehensive access to the anterior fossa, cavernous sinus, paraclinodizing, and clearance care in critical space, and after vision. The full anterolateral surface territory while preserving the temporal muscle function, restoring bone anatomy, minimizing the The mosaic concept is offered not as a replacement for all existing anterolateral approaches, but as the new specificating move that synthesizes the best elements of the new cranial transorbital endovascular surgery into coherent operative philosophy. This is my topic about mosaic, and I welcome you to all as I am the director of the Center of Neuroscience at College University, the head of neuroscience is over here, and we welcome all of you to visit our cadaveric lab, which is one of the best in class. We have done advanced 3D ultra micro neurosurgery laboratory with the help of the Sunmark exoscope, 3D exoscope with the robotic arm, as well as we are having the 4 laboratory features for the training of the neurosurgeons here, with the heads up 3D exoscopes, stereoscopes, displays, 3D displays, integrated AR technology as well. And we are having a lot of hybrid synthetic models, a lot of hands-on vascular anastomosis on chicken wings, and so on. So please do visit at our center to be a part of this journey. And this is my dear Gayatri, which is performing the suprabrow approach. this is our lab where you can see how we have developed this lab, and we are planning to organize the first NSSI training workshop in coming up month. So all of you are invited for this workshop. Soon our brochure will be online, and this is all the premises. So I would like to show one of the dissection video. So you can see this dissection with the AR technology with 3D electroscope by Sadma, and we are doing it the supra-brow approach, where with the small minimal approach you can see we are able to reach up to the IC complex. You can see the basilar, you can see the IC bifurcation, and laterally we are going towards the cavernous sinus as well. So I'm just running through the space of time. So with this mosaic approach, with a very, very small approach, you can have a 3D orientation of the IC complex. You have orientation of the cavernous sinus here. You can see the basilar tube here, optic, IC. And that's how we are training our program here. And thank you very much for giving me this opportunity and listening.
Thank you very much, Vikrant. We are also excited after we developed the mosaic approach. I think it is a time for surgical robotics to take over after some time, and for this minimally invasive approaches like the subtemporal route to the petrosal approach, expander, mosaic, all these approaches will now take the center stage instead of large craniotomy and so on. Multi-perspective will take the stage where endoscope, exoscope, everything sees what another is doing with virtual reality assistance. So thank you very much. And now we have 3 more speakers very soon. The first speaker is a surprise. She is a 10-year-old girl who will be talking about art in neurosurgery. Her name is Santana Cherianamathia, my younger daughter. And she will be talking about her art. And then we have Afsal, we have Juma, and then we have AI engines by Georgia from Greece. So this would be...
Doctor, we also have Australia?
Yes. Yes, of course, yes. So all these talks in the first session itself, and in the second session we again have speakers like Robert and yes, Sandra will be talking for 4 minutes. So let me share the screen for her. Yeah, so can you go on? Okay, you want to sit down and do it? Right, so how do you get in the presentation mode? Yeah. Right, can everybody see her presentation?
Yes, yes, we can do.
It is as disruptive as it gets.
Good morning, everybody. My name is Samsana Cherian, and I know that my presence here is very disruptive, as I've heard many times in this meeting. neurosurgery and innovation. So first is art is like neurosurgery. Now, I do think that art is different from neurosurgery, but it has similar features. Art is similar because it takes years to master, and I've been making art since as long as I can remember, and I still have loads to refine. Now, art has like three main heads. First is your sketch. Without a good sketch or base, your other two main heads will not be great. And anatomy. You can render your anatomy with references from videos or YouTube or Pinterest. Now, color render. Color render I don't like to do in my sketchbook, so I just leave it black and white, but I do it digitally. Now, all of them are hard and need lots of time to master. Now, these are some of my digital paintings.
You must give some time for us to appreciate.
Go back.
This one is a painting where I thought maybe I should use shading.
Self-portrait.
No, not a self-portrait.
Next.
And this one I randomly did. This is my first digital painting on IBIS Paintex. Then this one I'm very proud of.
Yeah. That one. Nice.
Now let's go on to innovations and neurosurgery being like universes. Now I feel like they are both in their own universes and people are like swimming in them and finding stars. And those stars are like ideas to bloom into great innovations for the neuro world and help save lives. But let's be honest, everything started because of one thing or person. Like Earth wouldn't have been there without the Big Bang, and if Walter Danley, Victor Horsley and Harvard Cushing hadn't pioneered the modern neurosurgery, then lives wouldn't have been saved and innovations wouldn't have been made. Thank you, and now I'm gonna hand it over to my dad.
Right, she made a lot of those paintings while on the flight on her phone, so I saw that and I told her she might do well in neurosurgery. I'll try to tempt her over to neurosurgery, but I don't know.
No, you didn't tempt me. I wanted to do neurosurgery myself.
Now we have...
May I say one word, please?
Huh?
May I say one word?
Yes, please.
Well, sometimes we look about neurosurgery, we are talking about innovation, about future neurosurgery, when the future is right here in front of us. This is the future. All the children is the future. They have the ideas. We must follow them.
Yes, absolutely.
That's all my comment. So, that's the future. Thank you. Chutki.
Now we stop the sharing, and now I guess Afzal, Juma, and then Georgia in that order. Keki, will you hand over? Will you handle the stage? And then after that, Ram Kumar and Raja will also talk about the ICUs and the exoscope. So, Keki, will you do the chairing?
After Juma and
Georgia.
Georgia, yeah. Okay. Right.
She's a very good friend of mine.
Yes.
We are honored to have you. We are honored to have you, man.
Same here, of course.
Okay, Kiki, you can do the chairing.
All right. So that we are, as we said, we are not on the cusp of on the cusp, but we are already disruption is going on, and you just heard a beautiful talk from the youngest member of our team, 11-year-old Santwana, and her perspectives on art and neurosurgery. We move on to a slightly older guy, Afzal, who still looks like a teenager. And Afzal is going to talk about his experiences and his perspective about neurosurgery in LMIC.
Yeah, I will give my talk on how to rather integrate this rapid advancement in technology in LMIC. So it's based on a little bit of research I did, and also my thoughts and speculations how it can be effectively incorporated. Now I had to kick myself out of Zoom because in order to share I had to make some settings change. So I hope to get back on right away. Pardon me.
You can turn towards here. Just here. You can turn towards here.
Can you let me in? Who is the host actually?
Ramya? Ramya?
Yes?
Afzal can be let in.
Yes, yes. It says joining. Okay.
Thank you.
Thank you.
So, try to share my screen now. So I hope you can see my screen now. So as it states here, my talk is on the integration of emerging technologies in training and treatment in the developing world. So why this is so important? As we know, the bulk of the world's population, that's around 85%, resides in the developing world. That accounts to almost 6.9 billion people. And the fact is that most of this population doesn't have access to adequate neurosurgical care within 2 hours of reach. The scale of the problem is also the distribution of neurosurgeons. So there is a shortage of 23,300 neurosurgeons worldwide, of course mostly again in the low and lower middle income countries. So as you can see, this first box here, there is a neurosurgeon density of just 0.12 in the low middle income countries. And there are actually 29 countries still that do not have any neurosurgeon at all. And the trainee density is also such that this shortage cannot be compensated in the next future. There are, for example, 35% of the low income countries doesn't have training programs even. Have been to Congo, for example. They have just 20 neurosurgeons for a population of 100 million, and they do not have a training program. They go to the Arabian, African regions or to other countries to train their neurosurgeons. What are the practical solutions to this problem? I did some research, and it seems that there are a lot of steps that have been already taken in this direction. I also know that my mentors like Professor Yoko Kato and Professor Cherian has also been doing years of really hard work in this direction. For example, telementoring and teleconsultation with the technology that we have available today is a very effective method to solve this problem, because it spares a lot of costs. There is no traveling involved. And of course, with the advent of AI and augmented reality, a person who is many miles away can assist in a surgery taking place in a different continent. This has not yet been effectively transferred to neurosurgery, but there has been a lot of papers where urologists have been doing urological surgeries in different continents. And the concept is actually not new to neurosurgery. As early as 1996, there has been some experiments in Japan where they did some experimental surgery tests successfully between Nagoya and Tokyo, and the distance between those two cities is around 350 kilometers. So with much more advanced technology like 5G and fiber networks today, I think this shouldn't be a problem anymore. And the latency of transfer of movements are also less than 2 milliseconds. So AI tutoring is another important and interesting concept. As early as 2023, that's like 3 years ago, there has been some test research that was done on GPT-4, and they found that GPT-4 actually significantly outperformed medical students and neurosurgery residents. Now we have much smarter AI, and I think they should be, in terms of knowledge, after a while of learning, they should be better than a lot of the people in terms of knowledge, because they can retrieve knowledge what they have. But of course the practical side of it is quite different. We all know that we all who sit here and who are on the TV from viewing this conference, we all use AI, and we all know that AIs hallucinate. But once they learn it and once they know that they have been hallucinating, they don't tend to do it anymore. So they're in the learning phase, and I think it will get better. AI tutoring has been shown to be much faster than classical learning, and human support, expert support with AI seems to beat AI alone. And this means that the combination is better for the surgery of the future and surgical training of the future. And of course, as Federico suggested earlier, simulations, he was suggesting about a much complex simulation. So, but even with 3D printed simulators, learning curve can be much steeper and faster. And these 3D printed models do not cost as much. So robotics and AI, if we like it or not, it will form a part of our routine, and it's better that we embrace it rather than go against it. As I see it, at least for the coming decade, not all centers in the developing world will be able to incorporate these highly costly systems into their departments. So what departments that have robotics and AI can do is organize teaching sessions to educate the fellow neurosurgeons, for example, in our case, to bring them to that level and make them ready for the future. So why robots are important? We already know that systems like ROSA have been shown to be effectively reduce error and increase accuracy and reduce operation time, and also post-operative complications in surgeries for electrode placement, etc. What are the real barriers? What the third or the developing world has? Connectivity. Connectivity is actually not a problem anymore. We have the solution, as Federico has been talking before. The technology is already there, and in case of medicine, some departments are using some technologies which other departments are not yet using, which are but of great use. So connectivity can be solved, of course, through 5G and offline AI programs. Capital cost can be reduced again through online communication and NGO partnerships and leasing if buying it is not possible, buying the technology and the machines are not possible. Faculty shortage can also be compensated through remote telemonitoring, which is already being done. The data bias, this is a big problem because most of the data comes from North America and Europe, and the developing regions are underrepresented in a way. So this should be a focus. This requires, of course, work to incorporate the patient data from the developing world also into the systems so that the output is more accurate. And cross-border rules are also a problem which need to be tackled through bilateral telesurgery and licensing frameworks. These are my thoughts on how to incorporate the rapid expansion of AI and robotics in low and middle income countries, which of course populate most of the people around the globe. Thank you so much.
Excellent. Do we take any questions here?
I'm open for questions.
Are there any comments or questions? We'd like to hear them from LMIC itself, if possible. Dr. Juma, do you have any comments?
Yes, it's a nice presentation. Thanks so much, Dr. Asfal. It's really true that in the low middle income countries, except South Africa itself and except North African countries, majority of Saharan Africans are really struggling with the issue of technology and artificial intelligence. But something which is promising, we have our regional societies, which now they have tried to make everything possible in our regions, like the curriculums. Now most of us are studying there. There's no need to go abroad for studying neurosurgery. Only technology and the issues that we have discussed, the barriers, connectivities, and most centers are centered in the cities. If you go just maybe 200 kilometers away from the city, then you are lost. Yeah, you're lost. So maybe this is something which he has said. I think we need to improve, and we are looking forward for further collaboration, as our government are also trying to push forward. Now CT scans are available in most of the parts, but MRIs, the Vega 12 things, we are missing them, so patients have to be referred to big centers a bit. Yeah, but I think slowly we are trying to improve.
We already have the WFNS sponsored centers of excellence in Rabat and in Nairobi and in South Africa and so on. So I think those were now almost 15 years ago. And since then, many more centers have emerged all across Africa. And the other thing is, so these centers should educate more and more, so within the country itself. But what Dr. Afzal said is there are some countries where there isn't even a single neurosurgeon. So that is a very pathetic situation. And you wonder what must be happening to these poor people who cannot travel anywhere or do not have in-house facilities. And therefore I am wondering whether apart from training doctors and neurosurgeons, whether it is also good to inform the lay people through various media, social media, television, something about neurology and neurosurgery, and something about centers which are available. And if those centers, those countries where it is not available, may put the politicians to, I would not say use the word shame, but they would put the politicians to realize that they are lagging behind the rest of the African countries, apart from the world. And that means give a little spur. I am aware that unfortunately many of these countries have corruption and governments are not stable, which is very important for the spread of science. And where even basic things like chickenpox or smallpox or cholera or malaria are still not overcome in many of these countries. We wonder how we can talk about something very esoteric like neurosurgery. But that was a condition 100 years ago in what we consider today as advanced countries. So you should not think and wait for somebody to say. I think individuals must make an effort in whatever way they can, and I must involve public, the local people, the general population, to be made aware that such a thing exists, that there is something called the brain and there is something called the nervous system which governs life, and how we can diagnose, because many years ago, in 1981, I removed what at that time was the world's largest brain tumor. It was a meningioma. The patient was from Yemen, and he had been suffering for about 1 year. 16-year-old boy who started complaining about headaches. He was given some painkiller, paracetamol. Then he started losing vision. he was given some eye drops. Then he started becoming drowsy, so they were doing something else. Until he became fully quadriplegic vegetative. And he was then transferred to Mumbai, to India, without any diagnosis. The CT scans had barely appeared even in Mumbai at that time. I'm talking about 1980, 81. And so I did an angiogram on this patient, stuck a needle in the carotid, diagnosed a large brain tumor, and then we made a film of this. I anticipated it would be one of the largest tumors that I've ever seen. And without CT scan, we operated. It turned out to be a 550 gram meningioma, which was successfully removed. I did not have a microscope in that particular hospital. I was using loop, and I removed the tumor. So we have the patient who is vegetative before as a video, as a those days we used to have those 16mm movies. We did not have a video camera. And then I'm taking a walk in the hospital campus with the boy after surgery. Wow. So this was a message to that country. And through that country, even when I was traveling to Middle East, in many of these countries, did not even have a CT scanner. When I first went to Oman in 1979, there was no CT scanner. So things have changed a lot. But things will change a lot if the governments are stable, if political problems are less, and the turmoil is less. So science can advance. But at the same time, advancements of science can also control political upheavals. So I think we have to talk at multiple levels to improve neurological or any medical facility. Talk at the medical level, at the diplomatic level, and also at the lay level. So I'm happy that we got some good insights from Dr. Afzal on LMIC, and there's a long way to go, but I'm telling you, with this technology, things may work much faster than the technology that we had, the primitive technology that I myself faced. Before the CT scan came, I was already a neurosurgeon by that time. So, thank you very much, Dr. Afzal, thank you. So our next speaker will be Dr. Juma, also from LMIC.
Yeah. Can everybody see my screen? Yes. Forward. Yes, good morning, good afternoon, depending where you are. My name is Dr. Juma Magogo Mzimbira. I'm from East Africa, Tanzania particularly, in Dar es Salaam. For those who don't know Tanzania, this is the land where we have the highest mountain in Africa. And it's the land of Serengeti and Zanzibar, for white beaches, lovers, and those who love white animals migration. This is the area. I work at the Muhimbili Orthopedic Institute, which is like a 500-bedded hospital in the city of Dar es Salaam, which deals with trauma and all aspects of surgery. So at the moment, we just do like general neurosurgeons. We do everything, but now people are trying to subspecialize. Like you are doing vascular, I'm doing epilepsy, I'm doing like this, pediatric, because at least the number has increased. So my focus will be on the evolution of African neurosurgery, as Dr. Keki and Dr. Afzal have said. Like in the early 90s, we barely had the neurosurgeon, especially in Tanzania. So before 90s. But after 1990s, yes, we had neurosurgeons who were trained as general surgeons first, and they went for fellowships abroad in Europe, particularly in Germany, where they did some fellowships. At least, I think it was 2 years. And then after the 2 years of fellowship, they came back. I think there were 2 of them. And after that, another neurosurgeon went for training in Japan. So we were depending on curriculums abroad. So it was until 2010, even myself, I did not find any curriculum. So I trained in China. And I did some fellowships in, can you see my screen now? So because of the limited specialist workforce in the independent area, so and the concentration of services are in the major cities, and we are depending on overseas training.
Juma, maximize the screen.
Maximizing. Okay.
Yeah.
Can you see now? Okay. So this is where I trained different places in India, in China, in some observership in the US. This was the funny guy. It's not really tough. So after 2000 to 2025, we started to have our own residence programs. As I speak now, we have like 4 training programs. We have the general surgery training, and then you do Masters of Science for neurosurgery, and we have a straightforward Masters of Medicine, straight neurosurgery course, which is 5 years, and then we have our societies, the COSEXA, College of Surgeons in East and Central Africa, including Congo, where now people can come and go to centers where they do neurosurgery, and then we train for 5 years. So, okay, you can move between centers, like from Tanzania to Kenya to Congo, in different specialties. This is called COSEXA, and there's one, it is called PAX, which is a Pan-African, it's a Christian-based university where they have their own training, but I think it's only in Kenya where they're going for training. There have been improvement in the neuroimaging equipment like CT scan. MRIs are still very limited to big centers, like in my countries, only in Dar es Salaam and the big cities like 5 of them. And we have 25 regions, so you can imagine still we need more MRIs to be equipped in different centers. So the milestones that we have is the development of regional training networks, the growth of subspecialties. Like now I want to go to Professor Ibe, thanks to Palo University and the team. I want to be mentored on the neurovascular surgery and scalpel. But also some people are going to Korea for neuroendovascular training. So we are going abroad for subspecialties, but we do most of the surgery. Spine, we're also doing the thing. Right now at our center we have the brain lab navigation. So we have a navigation system where we do the pre-op planning for the cases, and we do the surgery. I operated the scoliosis case with the brain lab navigation system. We can do it openly without any navigation, but we started now to use even we started to use the brain lab at least to get the accuracy and the precision when you're putting the screws. And the paper is under review. I published the paper. So I think in this digital era of AI, we need to improve on the telemedicine and the consultations, virtual reality, like the Federico has spoken of App Surgeon application, which is I think very useful too. And the only problem that Dr. Afsar said is the internet connectivity. Sometimes this has been a problem. We tried once with the Well Cornell Center in the US, where they were giving us, I have forgotten the name of the...
Starlink?
You take the Googles, and then someone from the US will be like directing us to do the surgery like this. But again, this was the major problem of the network, internet connectivity. So we could not do that study for the case, so we abandoned the study. But I think maybe we are still improving.
But now maybe Starlink is supposed to do it.
Okay, Starlink, yeah, maybe. In Kenya now they have, in Kenya they have installed Starlink. Maybe in my country I don't know what's the politics about it. They are still hesitating to get it, but maybe in the future they will call the guy and install the thing. So with the AI, artificial intelligence applications, it will help us with the imaging interpretations. Like the Professor Ibe has mentioned several times, it will help. The CT scan can even tell you, or if the patient is in the ICU, at least it can give you a clue and then get you a message. If you are maybe I'm in Greece, but I've operated a patient back home, I can get a message that this patient is changing conditions. So we would love to have this kind of AI thing, at least. And my country is open. We have even changed the curriculum. Now data science and artificial intelligence have been involved in the curriculum for in the university curriculums. So I think there is a promising future. I see that our president is trying to start developing this kind of stuff. But we need more research and data analytics for this, and we are open for those kind of applications to be installed in our country. So this is one of the papers. This is the case that I operated. It's the scoliosis AIS, addressing to the cases, scoliosis, where we use the blend line navigation system to try to put the screws. But we normally do on hands, just open hands, and we do the surgery. But we're also using the lab for tumors, for taking the biopsy in the brainstem. And that's it. But only two applications that we are doing. Robotics we have not installed, so there's no robotics. But I was told there are so many navigation systems that can be both the Sanma, Yoko applications, but we are looking forward to have them. Augmented and the virtual reality applications, we would love to have them. The 3D printing for the bones, skull bones, if the patient has a fracture. These are the things that we would love to have them so that we don't struggle with losing the bone flap. Most of the times if we store in the abdomen, we don't have a fridge to store, so we keep in the abdomen. Or else we used to throw it away and then we come back for the bone cement or titanium. So there are a lot of opportunities in Africa, and I think we are changing. We are evolving. Training is done there. It's just only to come, and if any center is interested, we can do some research regarding some cases. We can have applications like Upsurgeon, or if you know any of the applications that we can, you can be teaching while you are in India. That is okay for us, and I think a lot of young neurosurgeons are enthusiastic about learning AI applications. So that's it, what I have. Thank you so much. Thank you.
They say the world's population, the first man in the world came from Africa. So Africa should be actually leading the world and not lagging behind.
Sure.
And I am certain that your brains have, because of local problems, your brains have got exported to all parts of the world, especially to the developed world. So inherently, you are all gifted and you are all superbly endowed. And therefore, I think that the current decade will show a faster evolution and advances than any other country in terms of accepting modern technology. We are seeing these people all over the world and what they can achieve, whether it is academics or sport or anything. So I would also make a call that all these people who have run away from Africa to greener pastures should come back and support and bring some technology, bring some money, and also go into, as you mentioned about this making centers of excellence with a partnership with people who can afford to pay for it. And this is your contribution for everybody who has made money to give it back to society. So we see a bright future, and I think in the last few years, 5 or 10 years, if you compare to the earlier decade, the last decade has been phenomenally fast. And I think the next decade will get you at par. Unfortunately, you will lose all the concessions that you are getting by attending meetings. There are special rates for LMIC countries. But if you become too advanced, you will lose those advantages.
I have a comment to that. When I spend my time in Congo and in India and in Nepal, I always felt the surgeons doing the more complex cases should be the ones teaching the, now it's the other way around. I mean, the tumors we operate where I work in Germany are, I think it's a false way to describe it, sweet, cute compared to the complex cases. So if you understand what I get. So it's breathtaking, the complexity of the cases in Africa, and of course now people have learned, or people are learning very fast, and they are reaching the level what Japan has to offer, or what the developing world or Neurosurgery has to offer, and now they can do on their own. And I think it's very realistic that the time will come where Europeans and North Americans will come to Africa to learn.
Yes.
I think so. Yeah.
Yes, yes. And that is true.
Absolutely.
Yes. Yes. So, yes, I think we have to move on further, and I have pleasure to invite Miss Victoria, Georgia. She comes from the famous house of not the Armani.
Okay, can I have the share?
Desktop.
Only?
Yeah, I think you can share the desktop, or you can.
I cannot share my Chrome only.
Only your Chrome?
No.
No?
Oh.
Okay, super.
You might have to re-enter. It's good.
It's open. It's coming on.
Θα ξαναπάτε λίγο στο παράθυρο του Zoom.
Μισό λεπτάκι.
World Neurosurgery.
Nelson.
Yes.
Nelson, he came from Africa. He was in Nigeria.
Υπέροχο. Τα ξανανοίξαμε όλα.
Ωραία. Τώρα πηγαίνετε πάλι στο Zoom να ξανακάνετε share. Ανοίξτε το. Ωραία. Λέγεται. Δεν πάμε πάλι να κάνετε share.
Here we are.
Ωραία. Πατήστε allow. Για να δώσετε πρόσβαση στο Zoom.
Ωραία.
Θέλετε να το κάνετε που το ξέρετε.
Θα το κάνω. So, we're ready. Okay, first of all, I would like to thank you for inviting us here. We are Superbo, an AI company serving agentic solutions. Okay, my name is Georgia Panagopoulou, and let's take a few, not too many buzzwords. Okay, Opero is our platform. And just to tell you where we start, Our live deployments currently serve around 5 million customers daily. Okay, and we're our flagship, and we are proud of that in MTN Nigeria. Actually we were the first Gen AI assistant live globally according to Microsoft, and since November 2024 we moved to agentic solution. So we are not talking about a pilot anymore, we are talking about real production in Nigeria. We handle around 500,000 transactions per month, which of them the 95% is self-service, and they are handled fully from the system, okay? And what is impressive is that 3.5 interactions per second stay within the system before abandon or ask for human support. So we know hard places. We run in Sudan, in Congo, just to let you know, and it's really impressive. Imagine when we launched in Nigeria, nothing existed in the rest of the planet, okay? So the demo we have prepared, of course, uses our platform, okay, and it's not a pilot. And actually we started the use case I think mostly from our experience, because we are engineers, and we didn't want to arrive to the moment you are on the top of the patient inside the operating room. So we try to have a pre-operative exception layer on how the teams are ready to enter the operation the next day. So imagine here is what we will see in the demo. Actually, here you can see, let's say we have 3 patients for tomorrow. Okay, we have in our demo 9 domains that they are cross-checked. Okay, maybe the exceptions are somehow childish, but this is, you know, just to get the exceptions, and this was the important. And this will be, as you see here, it will be the outcome of what needs to be done. For example, we'll see the demo, but here for patient A, definitely needs human escalation, as opposite to the patient C that you see that the team resolved the issues and it's ready, and patient B was the easiest one that had no exceptions, okay? So from what you want, I would like you to see here is that actually we stay on the exceptions and the critical. The rest are handled by the system. So you can imagine the whole noise of the surgery and the surgery team. This is what we try to do, to move it out as soon as, you know, earlier possible, okay? So what it does actually on the plant services, okay, map require dependencies, etc. While, and this is more important for us, human keeps the ownership on the decisions, okay? I need to go to the demo. Can we see here?
Yes, we can see.
Okay, because I can't, so I'll focus on my screen. So here you will see we have the OER schedule for the 27th of June. Okay, you can see in the middle is where actually what the agent does, and this is part of the auditability that holds all the, I have not run it, you know, I'm just describing the sections within the screen, okay. And on the right, the white one down there, you'll see where the chatbot, after the results are there on how you may communicate when needed. Okay, so I'm running it. What's wrong? Είναι μικρό, Okay. Okay, and see, here we are done. As you can see, we have simulated also, let's go to the patient A. okay, that we've said before, it has the majority of the exceptions, okay? And here, on the conversational part, okay, we have that the patient is complete 5 exceptions. Everything was done. Okay, so the person who observes and checks asks to give more details and summary of the escalation of patient A that the problem was there. We have the summary, we have the evidence pack, so anyone can go there and check based on what this decision has made. Okay, and then it can send the WhatsApp message, okay, for the exceptions to the doctor that is responsible for this surgery. Okay. So with the same, you can see that patient B is clean, can follow, okay, and patient C, they were taking some actions and is ready for the OR. That's simple, that's fast. Okay, but you can imagine this as we discussed it yesterday, okay, as any conversational layer on the top of your tools. I will not go there, we don't have the experience, but we know what we can offer. Okay, plus also agentic solutions agents between your machines, doing the machine to machine as it is here. Okay, and on the top conversational or voice in a later on stage. I think I was fast. Yes. For the 5 minutes. Okay. Would you like we see something more in detail in the demo? I will share it with you anyways. Okay. And that's from my side.
Okay. Excellent.
Questions? Or Agiris, they want to add something? No. Okay.
Yeah.
I think you can imagine how this can be. I didn't want to go further, you know, this is our personal experience from hospitals.
So, I have one question.
Yeah.
What we wanted to demonstrate is how an AI agent can help your residents or your doctors before they enter the operating room, so they will do a check with all your systems, so that everything is in place, and give you the go or no go for the surgery. They can flag you and say, okay, this in this case you need some extra exams, or if the exams are too old, you need to repeat them, and flag the surgeon. So it's just fail safe for you for your job before you enter the operating room. That was the purpose of this AI.
Yeah, and the moment you want to have this check, you know, not last minute, it can be the night before, or when you have time. All of this can be configurable or can be run manually, for example. Okay.
You showed a nice case of a lumbar disc L4, L5, and I had the occasion of having this experience once when a person had very bad back pain and sciatica, and it showed a large disc bulge, and he was on a wait list for surgery. And in about 6 weeks' time, he felt better, a little better. However, the MRI was repeated, and the MRI showed that disc bulge had vanished. Now, had we operated on the old MRI, we would have probably found nothing significant. So, what your AI has done is that it has identified that there is a lacuna in your latest investigation. You need to show, even when we transfer patients sometimes from another hospital or university to our place, they come with a certain CT scan which was done one day earlier. Things can change dramatically in 24 hours. So our standard instructions are that you must investigate them the moment they enter the hospital once again and know the situation.
Correct.
So what we are doing is, you know, based on our experience. But once you have a protocol like this, then...
And sorry to interrupt you, what we discussed yesterday, because now we've seen the pre-operation.
Yes.
We have the during, and actually what we discussed with Vasilis that I find it very interesting is the post-operation,
Yes.
where you have the actual patient being part of that as the quality and also statistics from your side, reducing phone calls, because, for example, okay, today my fever is 37, response, okay, keep following and come back when it's 35.8, 4.5, for example. And only then the system will alert the doctor. For me, because there we also provide, I love customer experience, okay, and we give some trust also to the patient that I think is really essential, that nowadays you are just calling the doctor maybe from psychological reasons or whatever. And so that's how we have it in our minds that this can be established.
If all the clinical information is given in the post-operative period, can your this AI be able to outline the possible way to proceed, to treat or to investigate further?
Yeah.
Also?
Yeah.
Yes.
This is clinical judgment module.
Yeah.
Yes.
This is happening now in most
Yes.
ICUs. It's happening.
Yes.
We are working with it, and I was telling
Yes.
her.
Yeah, we said, yeah.
Yes.
We are bringing an ICU system called the Netra.
Yeah.
It is called Netra, the sentient ICU.
Yes.
Sentient meaning it knows everything.
Yes.
So from there,
Yes.
this can be a layer on the top.
Yes. Yes. Only thing is that if it becomes a protocol, it can be challenged in the court of law. For example, a clinician will go by his clinical experience and may not be guided by AI. And then the question arises, if something goes wrong, and if this AI protocol is already available, and if the clinician has taken a different decision from what AI has to give.
Imagine that our systems, from what we have seen now, even in sensitive sectors, okay, the AI will contact a human or issue an alert when there is a risk. And this is part of the solution. It has to be, it does not hallucinate like the LLMs and the rest of the stuff. It's very well governed, not to take any decision upon uncertainty. Okay, so this is something we are working very hard to be there. So until we reach the maturity level of the LLM, it's better to involve humans. And as I said, the quality needs to come from us, from the Homo sapiens. Otherwise, they will never be trained correct.
Exactly.
Okay, we need them to do the repetitive tasks.
Basic clinical.
Yeah.
Only a good clinician can get better.
Yeah.
A bad clinician cannot become.
And to support.
It's a decision support tool.
Yes.
And for me, when I
support the agent, but what we're trying to do is to give all the tools that the AI needs to give you a better recommendation.
Yeah.
So that you will make a better decision.
So if you see in other demos, for example, we have, if it is a doctor there or a call center, it can be whomever, it gets the answer very as it is by the system, and the answer we provide to the customer is completely different. We propose what to answer to the customer, and we keep there the safety nets on the top of the human. Okay. And when we discussed with Vasily, this is for me, it was, I would like to, first of all, to remove the noise from their heads and around and let you do the actual job, because AI cannot operate brain, that's for sure. So you have to do it, and to have it with less noise, as less as possible.
How does it work? Is it integrated in the health management information system of the hospital?
It talks to it, yes.
It talks. Yeah.
Okay,
It will be installed either in your depending on the facilities you have in your local hospital, let's say, and it will talk with your database, your systems, your through APIs, and will collect the data. And then it will talk to the anonymized data, and if needed, send them to an LLM of your choosing, and will communicate like this.
So what you said before, because I've been in Africa 3 years, okay, myself, with eHealth Africa during Ebola. Okay, the off-net data synchronization, okay, you may not be 100% accurate like you were, for example, in Seoul or in Delhi or wherever, but you can have, you can synchronize upon you have network, but definitely you will have a very strong tool. Either you are offline. Okay.
So it can be offline as well.
There is a way
There
to
is a
deploy
way,
your premise.
yes.
It's expensive.
It's
as
more
things are now,
expensive.
because you need specialized equipment.
Okay.
But to run the
But you can
locally,
run.
but yes.
You can run it locally.
Okay. And it works in all disciplines like neurosurgery, gynecology, urology.
It depends on the library.
Well,
of,
challenges
of,
in
of
Africa,
the
there are so
knowledge
many
base.
challenges. I mean, think of, for example, pregnant women in the villages. And maybe it can give you a clue, this is an obstructed labor, so we rush the patient to the center. Like, not necessarily in the big cities, but you can work even in the primary health care, the small hospitals, just for referral system.
Yeah.
It can run somewhere centrally and can be accessed through WhatsApp. You have WhatsApp from everybody.
Yes.
Yeah.
Everyone has WhatsApp in Africa.
Yes,
That's why we know it's WhatsApp or
one central deployment, and then everyone can chat with it through WhatsApp.
Yeah. Yeah. So there are solutions. Imagine we also run in Sudan, so we have found solutions.
In Sudan.
In Sudan. So Tanzania, you can imagine it's the paradise.
Yes, I think so.
We come from the hard places anyways. But for us it was opportunity in Africa, to move directly to AI solutions.
I think it's a nice tool, a very supportive tool.
Yeah.
Very good one for our region.
With our poor knowledge, anyways, I hope we managed to. Thank you so much for asking for us. Thank you for having us here.
Your contacts to Dr. Ivan or take
Yeah, I will give you a card. No, yeah. Thank you.
Very much.
Thank you.
We break for lunch now. The session will end.
Okay. Ναι, να πάρεις και εσύ το...
disruptive as they come. I know Roberto for the last 15 years or so. And from the time I have seen him back in United States when we were teaching together in Salim's courses in St. Louis, he has struck me as the type of man who not only does disruptions, but he has the most open mind. Unlike a lot of other people his age, he is like a child at heart. And he promotes disruptions, he promotes innovations, and he's a forerunner for innovations. He's one of the people on the planet, if not the person on the planet with the maximum IMRI experience. And as I had an IMRI 10 years back, and I hardly used it because it was a 2-room solution. I realized it later, but Roberto figured it out, and he has a 1-room solution, which is one of the very best. And his glamour surgery is something from the future. Now, I am so honored, my friend. He came today 2 a.m. from Buenos Aires, at which time I called him up, and right now he's ready for the talk. So that speaks volumes about his commitment. Before Roberto starts his talk, I'm going to show you again this Villa Congress, so which we want Roberto to join. Next time we are doing this Villa Congress, we want you to join as well. So that is the Greek Riviera, and this is where the Congress is going on. So Roberto, the next time we want you to be here. And with that, I would want Roberto to start his session. We are all in attendance.
Thank you, IP. Thank you for your kind words. Thank you very much. You are in an amazing country. I love Greece and the food of the Greece. Yes, I hope to be there with all of you next time. Thank you very much. Thank you for inviting me to participate, to share this meeting with you. I'm ready. If you decide, I can share my screen.
You can start, Roberto, please. You can start.
But I need to share my screen. Compartir, yes. Here is. Okay. This is one of my view of Greece last time in this country. Okay, I'm going to talk about our experience with intraoperative MRI. This is our clinic. You are invited to know our department in Buenos Aires. I think with IP we are planning in the next future to do one of these meetings in Buenos Aires in Argentina. It will be my honor. And this is my first question. Are these real glioma treatment results, or are these values based on incomplete surgical resection that we must to shift, we must to change? What does the medical literature say about this? In low-grade gliomas, surgery, gross total resection is the best prognostic factor. We don't have that about this. Gross total resection is the same that years, decades of survival, probably cure of these patients. But with subtotal resection, early progression, a few years, and the death of the patients. Most of the patients with incomplete low-grade glioma removal resection die in few years, in 3, 5, 7 years, from recurrence or for malignant transformation of the tumor. In high-grade gliomas, the situation is something more difficult, but gross total resection improves quality and to the time of survival in the patient. And the guidance recommend in both maximal safe resection feasible in low-grade gliomas and in high-grade glioma. But it is not easy because mainly low-grade glioma are very similar to normal brain. And we don't know where is the tumor really, which are the limits of the tumor, where the tumor begins or ends. That's why in some series of glioma surgeries, the number of gross total resection has been only 6, 10, 12% of the cases. And what happened? If we make a subtotal resection in low-grade glioma, talking about low-grade glioma, in less than 10 years' time, we would be losing more than 50% of our operated patients. And it is very important because we are talking of a young population of patients, young men, young ladies, children, teenagers. This is the victims in low-grade in most of the low-grade gliomas. We have a lot of tools. Yes, of course, we are use everything that we can use to do a better surgery. But I think it is the time of use images into the operating room. It is the time of intraoperative MRI. Gliomas operated using low-field intraoperative MRI in the last 25, near 26 years. And Argentina was the 5th country in the world where a tumor was operated using intraoperative MRI. This was our second intraoperative MRI in Buenos Aires. We have a new device now I'm going to show you in this conference. But this is an important point because this baby was the first low-grade glioma that we operated in Argentina on July 2000 with this extraventricular neurocytoma. This is the baby, and this is his mother. We removed completely using MRI, and this is the boy 10 years after surgery. Here you can see him 20 years, and this is him nowadays. He is living, currently residing in London, and this is a similar picture, the boy with his mother. 26 years after surgery, living completely normal life. This is pre-operated, and this is the boy nowadays. And we have similar experience in most of the low-grade glioma when we would be able to remove completely this tumor. This case was oligodendroglioma operated in 2006, a great tumor here. We remove it. And you can see the patient 20 years after surgery, MRI completely normal. 20 years post-operative. This is, I think, the only case in the world who is with life after being operated of two tumors, two low-grade gliomas, on the left and the right. We operated in a first time temporal lobe tumor, then the second. This is, we removed completely the temporal lobe glioma. 2 months later, we operated the other tumor in this location, post-central area. And this is one of the control, 7 years post-operative. The patient with his family, 10 years, 14 years, 18 years post-operative. And this is, you can see here, this is April this year. This is his MRI. No tumor here, no tumor here. Patient completely normal. I think he is cured definitively of this glioma. And this with his family. And we have a lot of cases like this premotor area in a young woman with this grade of removal. The patient 16 years postoperative here in the postoperative, and this is the woman with her family, the children, 2 children, completely normal life. In this diffuse and infiltrated tumors, left frontal lobe, we remove it using anatomy. Of course, anatomy is number one. Anatomy is the most important, but we need the image because anatomy is changing because the shift, because the tumor. This is premotor area. We have a lot of patients with premotor area tumor with this grade of resection, 15 years survival. Another similar tumor, left frontal lobe here. You can see the tumor when we open. We detected with intraoperative MRI this tumor remnant here. We removed this piece, small piece of tumor. And this is the patient several years later with no more tumor. And the patient is very good because the tumor hasn't functioned. If you remove tumor and preserve the normal brain around the tumor, the patient will be better than previously to the surgery. Other case, we operated this lady, 25 years old, in 2005, and you can see complete removal of the tumor. And this is the patient, 21 years follow-up, 21, completely normal. This huge tumor, it is impossible to operate away this tumor. And we can check with intraoperative MRI with our old device, and we can achieve this resection. And this is the patient 5 years post-operative without neurological dysfunction. In children, it's very, very useful to use the image to guide the surgery. In this insular tumor in a 3-year-old boy, 3 years old, we operated him in 2009. This is the boy, you can see here, a little boy. This is the aspect of the brain, normal. We open the cerebral fissure, we remove the tumor here, and this is one of the images. Here you can see the head is still open. And with this tumor remnant here, important tumor remnant, and this is the last intraoperative MRI. The head is open. And this is the boy a few days after surgery, completely normal. And this is the patient 4 years post-operative. This is the history of the low-grade gliomas that we are seeing when we do postoperative MRI along the time. And this is the boy nowadays, and this is the last MRI, 15 years postoperative. It's very, very useful in this kind of gliomas where the limits are very important. You can have a lot of tools, but I think the most effective is intraoperative MRI. You can see here, we do this. This is the rate of resection. This is the typical, the normal microsurgical resection. This is the middle cerebral artery, and this is the patient in a few days and several months after surgery, and this is the MRI. No more tumor. This is to remove the tumor. No partial removal or biopsy of the tumor. And this is which really change the evolution of the patient. You can see this last example. This patient was operated in Germany, August 2004, 2 years old baby girl, a little girl, little girl. But the patient came to my office with this tumor remnant here, with this tumor, and very difficult tumor because it is in central area, not easy to operate. We decided to remove it because it was an oligodendroglioma too. We decided to remove this tumor, difficult tumor with these deepest areas here. But this is the girl 10 days after surgery, 1 month, enjoying winter holidays with her family. And this is the lady. This MRI was taken in 2017. This is the patient in Disneyland in the United States. And this is the difference. With partial resection, with this kind of resection, it is incompatible with the life. But with this resection, this is the patient 19 years postoperative, and this is the patient nowadays. He finished the high school. This is partial removal, this is complete removal, and this is the patient. It is very important to accept this difference. It is because it is not the same to open the hair, remove a piece of tumor. Oh, this tumor was operated. No, this tumor wasn't operated. You have to remove the tumor, mainly in high-grade glioma. That's why I'm completely convinced that this is not the final evolution of glioma in glioma surgery. We be able to do better this kind of surgery. What our master monsters of neurosurgery said, Professor Shastakil in 1984, he said that I'm convinced the time will come when the neurosurgeon might examine and check in the future operating rooms, whenever he needs it with images in 3D, the step of each surgery, said Professor Shastakil. Previously to the intraoperative MRI were used in neurosurgery. When Professor Almesti visited Argentina, he said, I see an intraoperative MRI in every neurosurgery operating room of the future. And Professor Sami, in 2017, I had the movie, he said, nobody wants to be operated for a glioma without having the control during their surgery. Therefore, said Sami, we don't need to discuss about it if it is necessary or it is not necessary. If you have intraoperative MRI, you have advantages, of course, you have advantages. Blind surgery is unacceptable in modern neurosurgery. We have to see what we are doing during the surgery. Professor Berger you can see this presentation of Professor Michael Berger in YouTube. And he said, the future of glioma surgery is the low-field intraoperative MRI image-guided navigation, said Professor Berger. And I expect us to have a commercially low-field and available system within 3 years. You can see this conference in YouTube. My good friend, Hyper, who had this amazing operating room. I think it is the best operating room I see around the world, completely, robot, CT scan, MRI, 3 Tesla intraoperative MRI, but he said now that he's working now in Medaranja project. I think this is the future, and with integrated technology into the operating room and using a small intraoperative MRI. I'm going to show you the device that we are using in the last 3 years in Buenos Aires. This is a design from Italian company, Isaote company. This is the head completely compatible with the MRI. This is the device, 0.25 Tesla. We published in European Society of Medicine 2 years ago our first 28 procedures operated using this new device. And last year, on September, we won the senior award from our Neurosurgical Argentinian Association. And we presented it in several meetings. Recently in United States, this is my presentation in European Congress in Dubai. We are talking about this. This is the device. We have the possibility to have dedicated coils, specific coils, and with this simple rotation movement, we put the patient in surgical in position to images acquisition, and here you can see you can move the patient. This is the headrest, and put the patient into the magnet, out the magnet, with a simple rotation of the stretcher. This is the moment you get the MRI, or you move the patient in the opposite way and go on with the surgery. I'm going to show some cases operated with this device that we are using. You can use exoscope, endoscope. You can use everything. The rest of the devices that we need to operate. And this is a simple, practical, easy to use, fast, neurosurgeon friendly. And the most important is that with these kind of devices, you respect the condition of the normal surgery, conventional neurosurgery. This is our operating theater. And how we do that? You operate in normal way. You can use your own microscope, bipolar coagulation, ultra ECUSA. You can operate the WEG if you prefer. You can use all normal instruments for the surgery. Here we are doing the craniotomy, for example. And this is the view from the technical area that is in the surgical area. When you decide to check the surgery, simply you cover the patient with this sterile field, and with this simple rotational movement, one person with one hand put the patient in the center of the magnet and put the coil, you can see here, in less than 4 minutes, you can have one complete sequence in T1 with contrast, with gadolinium, or T2 or flare, then that you need at this moment. And you have this opportunity of the second chance. You can check and reevaluate each step of the surgery and go on or solve the removal. This is a case operated with this new device, with this frontoinsular tumor here. This is, you can detect this tumor here. And this is MRI, preoperative MRI with this. This is the tumor. And this is the first intraoperative MRI we did. You can see this tumor remnant here, tumor remnant here, and tumor remnant here. We go on with the surgery. This is the second control, intraoperative control, and you can see this tumor remnant here, a thin layer of tumor, even in the depth of the cavity. And this is the last control. The head is still open here, and after removing completely the tumor. And this is the high field MRI, 3 months post-operative high field MRI, with no tumor in T1, no tumor in T2. This is a complete gross total resection, and this is the surgical field, and this is the patient. In a few days, you can see the scar here. It's a few days after surgery, patient completely normal, a young lady. In this is another case, this huge, low-grade glioma, and it's the same. You can use the patient with, you can operate the patient in prone position. You can use navigator if you decide. Here you can see, and this is my normal microscope. My normal microscope. This is intraoperative MRI, a mark at the bottom of the cavity after removing the tumor. This is the surgical bed, and this is the high field 3 Tesla postoperative MRI with no tumor and this is the surgical bed, the volumetric resection of the tumor, and this is the patient 2 months after surgery with his wife here, completely normal. Very difficult in high-grade glioma to butterfly wing, 3-year survival with this grade of removal. This is intraoperative MRI. You can guide the surgery with these images. In high-grade glioma, it's very useful too. You can see this tumor. This is the sequence. Here, when we start the removal of the tumor with this remnant here, less tumor here, and the final control in coronal sequencing. This is in axial sequencing. This is sagittal sequencing. This is the first approach, the second, the last approach, and this is the patient, completely normal after this amazing removal of the tumor with 26 months after GBM removal. Midline tumors, you can use it for midline tumors without problem. And this is the approach, transcortical approach, and this is in a young lady, the grade of removal of the tumor, complete removal in low-grade glioma too. And I think we will see in the future this integrated operating room with intraoperative MRI, neuronavigation, the robotic, perhaps virtual reality, artificial intelligence. Perhaps in some rich countries, we will be able to see this in no much time in advance. But nowadays, I think intraoperative MRI is here. Intraoperative MRI, we can use now intraoperative MRI. And I think that intraoperative imaging in glioma surgery is now, is present. And I think that intraoperative MRI won his time. This is its time. Thank you. Thank you very much. This is all for me.
Roberto, what an amazing lecture. What an amazing lecture. I mean, this is truly the future. And I believe this is what we are investing into. And we are confident and proud. And once the IMRI comes into Parul, I would be honored to have you there. So would Svetlana, Raja, and Amol, all the team, and as well as the Parul administration. Gitika and Komal and Vikrant and all of us would be very proud to have you there as one of the pioneers of this treatment. And we would want you to spend some time and advise us on how is your experience on this. And I'm sure you'll be impressed with how we have fused the exoscope, AI, machine learning, machine vision, everything into Medharanya.
Yes, I don't have doubt in you. I think you are the great leader in many for the new generations of neurosurgery, and you can count with me for everything what you need. I'm completely convinced that this, and it's very difficult because the cost of these technologies until now, and I think we have to democratize the use of the new technologies for put it at the hand of all countries, rich and poor countries, developed or undeveloped countries, to the neurosurgeon having the future, in the next future, the same possibility when they are operating glioma in Argentina, United States, in India, in Nepal. I think the patients, our patient, have to have the same possibilities when they suffer of one of these tumors. Thank you. It will be my pleasure to visit you in your university in India, of course.
Thank you so much, Roberto. Honored to have you here. The next talk would be from Sanma. The owner of Sanma, Mr. Ram Kumar, will be talking about the intuitive robotic exoscope and how we reached there from starting as a company which dealt with microscopes, what was the journey for us to start with a simple exoscope, then go into generation 1, Sanma Yoko, and then the generation 2, and finally the intuitive robot, which is at present probably the best exoscope in the world, with 150 magnification, intuitiveness, and link to all the Medharanya with VR, AR, everything. So the scope itself is intelligent. So we would like to hear from Ram Kumar. Are you there, Ram Kumar?
Yes, doctor. Good afternoon. Hi, everyone. I sincerely thank WFNS Innovation Technical Committee. And once again, thank you, Dr. Aibcherian and Veselas, sir, for allowing me to detail about the Sanma Eco Exoscope robotic exoscope. So just I will share, allow me to share my screen. Can everyone view my screen? Hello? Hello?
Yes, we can see it. Yes.
Yeah. So Sanma makes a surgical operating microscope and exoscope for spine, brain, spine, ophthalmology, ENT, plastic surgery, and micro hand surgery. So Sanma is 25 years excellence in optics and optomechanical engineering. For the past 25 years, we have been focused on only in the optics for surgical operating microscopes. So I thank Dr. Cherian sir for allowing me to once again talk about the echo exoscope in this forum. So about exoscope, the most exciting advancements in the modern surgical visualization is the evolution of exoscope, and particularly thanks for the emergence of robotic and 3D technology on this. The microsurgery has always been driven by one fundamental principle, is the ability to see the clear magnification. From the early days of magnifying loops to the continuous development of operating microscopes, every technological advancement has aimed to improve precision for the surgical view, best surgical view. And for decades, the surgical microscopes has remained a gold standard in microsurgery. It transformed surgeons' approach to delicate anatomy and the procedures that were once considered impossible. However, despite its enormous contribution, mostly the surgical demands are changing rapidly. And today's the next-gen surgeons require more than navigation alone, is the better ergonomics, digital integration, enhanced workflow efficiency, shared visualization operating room, intelligent positioning systems, and compatibility with modern operating room technologies. So this is where the echo exoscope represents a major shift in the microsurgical visualization in the new era. Sanma Yoko is essentially a high-definition 3D external visualization system that replaces the traditional IPS-based microscopes, comforts surgeons with a digital 3D imaging platform. Instead of looking through binoculars, the surgeon operates while viewing the large 3D monitor in a natural heads-up posture. And the Yoko exoscope provides Ultra HD 4K 3D imaging view with exceptional depth perception, contrast, and color accuracy. For the neurovascular structures, tissue plans can be visualized with remarkable clarity on the screen. In the modern operating rooms are becoming increasingly connected to environments like navigation systems, imaging platforms, augmented reality, recording technologies are now inevitable features of advanced surgery. So here the Yoko integrates naturally into this ecosystem. And not only that, the next major advancements in digital integration is we'll look forward the futures surgical visualization will continually evolving optics alone. Apart from that, artificial intelligence, augmented reality, robotic automation, and digital will increasingly become part of the surgical workflow. The Yoko exoscope offers the features like a point lock, memory positioning, continuous zoom magnification, where we can view the 7 mm field in 90x, and continuous variable focus 200 to 1000 mm, and ICG IR 800, yellow 560, 3D 4K resolution, live 3D 2D video recording, and still image. And it can be stored in internal hard disk storage of 4 TB, and high resolution 3D 4K monitor, 55-inch and 32-inch, with motorized positioning monitor cart. And it also compatible with virtual reality, digitalized controls, the wireless foot switch with 14 functions for the optical head and robotic controls, and finally the navigation integration facilities. The Yoko exoscope are not merely as microscope alternatives, but need of operating rooms. Last but not least, the Yoko exoscope is not just another surgical device, it is a platform for the future of intelligent ultra-microsurgery. However, despite all technological advancements, one thing always central is the surgeon. Sunma is not replacing the surgical skill, despite enhancing surgeon's capability. The way that is the true purpose of robotic 3D exoscope innovation from Sunma. So thank you all for the time and opportunity.
Hello?
Hello?
Yeah, thank you so much, Ram Kumar, for giving a detailed thing on the Sanma Yoko exoscope. And you guys have been so disruptive and so amazing to develop this exoscope. And next, let me call Raja Alagaraja from Time Medicals to talk on the disruptive innovations from Time Medicals.
Yeah. Thank you for the opportunity, doctor. Thank you, sir.
You're welcome, and we are honored to have you, Ram Kumar.
Thank you, sir.
Hi, everyone, and thank you. Let me start sharing my screen. Hope everyone is able to see my screen. And am I loud and clear?
Yes, we can hear you.
Fantastic. First of all, before I start, I would want to thank you so much for having us. And I would want to start saying that I'm genuinely, that being in this room, in this perspective Zoom, is something that I'm really, truly proud of. The clinical team in front of us represents the kind of expertise that humbles us in the moment of you actually walk in. So thank you very much for the opportunity, and special thanks to Dr. Aib Cheri. So we are here today because the committee, WFNS committee, believed that this conversation was really worth having, and we are grateful for that. And we do not intend to waste much of a time, so I would directly wanted to run through on what I am trying to project it out. So I'm here to talk about a smart ICU platform from Flynn. It is called Flynn IUCU, and what it is a critical care intelligence built together with clinicians. And when we talk about together, so one thing that I actually wanted to say is that so this was not whatever you're going to see was not built in a boardroom. It was built in ICUs at odd hours next to specialists, clinicians who are very patient enough to actually show us the challenges that they actually faced and trusted us to take them very seriously. And I would actually thank them on that. And when it actually comes to ICU, there are 3 or 4 things that we actually put an emphasis on. Every second counts, and the best part is going forward, every second would be counted. That's what it is going to be. And because it is a critical care unit, the difference between the information and intelligence is not anything, but it is life itself. So that's where we actually focuses on. And we were actually talking about we getting into the clinicians at odd hours, which comes to the problem statement that we were actually said to actually foresee. So 3 a.m. Consider this is the problem statement, or one of the problem statement that we might actually look at. It's a 3 a.m. A nurse calls, a patient BP has just dropped, and you actually have 12 patients. The clinician typically has 12 patients across 2 hospitals, and the clinician haven't seen the patient vitals trend as is. The last note in the EMR was actually typed, say for instance, at 9 p.m. or 10 p.m., and that was typed in manually. And at this moment, if you actually look at it, it actually captures 3 systemic failures, if you have to put it out that way. One, it is not reactive. It is reactive, not proactive. And data is fragmented across devices and charts, and 30 to 40% of every shift is typing, not treating. And everything that we have actually built around it is a direct answer to that a moment itself. How do we actually wanted to do it? That's why we actually bought an IUCU, an AI powered critical care intelligent platform. And we have actually sifted into 6 different solutions or modules, if I actually have to say. And of course, this would be enhanced by something that I would eventually talk about in coming slides. But to start with, I actually wanted to focus on these 4, which is to start with Walk, wherein it's a voice-powered AI transcription and EMR autofill, wherein a nurse or a doctor can speak in any language. I've just put in India language, but it can speak in any language. It actually extracts the snow mead CT structure data and fills the EMR automatically, and there is no typing, typical typing needed at all. Will that alone help? No. We also have Seva, which is a AI clinical QA grounded in a validated ICU protocol, which will be available 24/7, which is an agent itself. And what would it do? It's a protocol grounded Q&A. So a nurse can typically ask clinical question in their own language and get an ICM validated answer at the odd hour that we are talking about, which is the 3 a.m. itself. And one of other painful point that we actually saw is generation of discharge summary. Collating all the discharge summary in one entity is again one of the major challenges that we see. So what we have actually done is AI, which actually generates on one click of an accurate, comprehensive patient's discharge document. So on one click, generate a complete structured discharge summary for all EMR data, which will be created or compatible with any of the EMR system, which eliminates the documentation backlog that you generally do. And last but not least, both, which is a clinical decision support system enabled, powered by AI again, which is a differential diagnosis with the probability scoring across 20 ISCM protocols. So what it does is it actually takes symptoms, it actually takes information from vitals, it takes from information from lab, and then it actually gives you a rank diagnosis. And this is why we actually generally need you. So based on symptom, vitals, lab procedures, a rank differential, the AI structures the reasoning, the clinician decides. So it is not the AI that actually decides, it is the clinician that it actually decides. Followed by it is the real-time hub that we are actually talking about. Today, nurse read vitals and calls the clinicians. Tomorrow, every monitor should stream live to the clinician's dashboards. That's what we are actually working on. So assume tomorrow every monitor at every facility streams live to your dashboards. Of course, it actually uses like HL7, fire from any bedside devices, ventilators, infusion pumps, ECG waveforms, all unified as one hub. And alerts ranked by the clinical severity, not by which alarm fired first. Every but every facility color coded by the acuity. That's what we actually wanted to go on. And on one screen that actually tells you where to look before anyone picks up the phone. That's what we are actually trying to do eventually. And when we talk about both, we were actually talking about clinical decision support system and whatnot. What is the core thing that it actually would differentiate is early warning. So in any ICU, most of the time, what happens is it is T minus 0 is when the nurse calls, which is too late. That's something that we actually wanted to avoid. At this point in time, of course, we actually say T minus 6 hours, which is 6 hours before. Assume that Ayu Raksha flags risking ICP risk, and clinicians intervene, and wherein you actually have ambient cameras, the sensors, watch every patient continuously. And when we talk about watch every patient continuously, the immediate thought or immediate perception is, oh, there is going to be variable, there is going to be manual observation rounds. No, it is going to be no variables, no manual observation rounds, and anything. And you actually have the sensors watch every patient continuously. That's where we are actually going on. And the predict that we're actually talking about is organ failure forecasting 4 to 8 hours ahead, like AKI, cardiac decompression, respiratory failure, septic cascade, everything not at the 0th hour, but 0 minus X number of hours, and X can be 6 hours, 8 hours, a minimum at least 4 hours. And when you actually have the data, when you have predict, when you have the sense and the predict put together, what would the other thing that you need to do? You need to actually act, right? It's a protocol driven care that actually prompts suggested in real time. The clinicians confirms with one tap, is always in control, and it has never been bypassed. That's what we are actually looking at. And finally, these are core connecting the patient, the nurse, and the clinicians, yes. But one of the core thing and all these is the family transplant layer, which is the Senti Connect. The families receive real-time conditions, updates in their own language. So zero nurse time spent, or probably less nurse time spent answering the status calls. That is one of the core things that people actually are spending time also equally, wherein they need to focus on eventually on the patient itself. And of course, one of the core thing when we talk about sentient is the sentient bed itself. This is going to be, as we've been having all along, a disruptive bed that will actually come into picture. No variables, no bedside monitors, no repositioning rounds. The bed itself is an ICU. That's where we are actually going on. So assume that the an ASL mattress that continuously shifts pressure points, zero bed sore risk, no repositioning rounds at all. Assume that pulse, SpO2, ECG sense with the mattress, no chest electrodes, no clip sensors, no monitor tower, and you'd still actually get the live data eventually. Then compliance sensors that detect early DVT during the massage cycles and automatically reverse the massage pattern to counter the clot formation itself. That is going to happen. And the pre-practitioner delivered by above IUCNT recommendation that you saw for airway clearance in incubated patients. So no manual, or I would say less manual physio rounds needed. So the core objective here is no variables, no bedside monitor towers. The bed itself is an ICU. That's where we are actually going to do. So one more idea that I think is underappreciated is every patient who is awake and alert doesn't need to be in ICU, right? The ICU is for patients who cannot survive without it. So the RU-CENTI score steps down readiness continuously, and when the criteria are met, the system flags the HDU readiness, your team reviews it, and then you decide. The same safety net applies in HDU also at a learner nurse ratio. The ward gets into an auto-generated discharge summary the moment the patient arrives. So every premature ICU day avoided is one critical bed freed for the patient who truly needs it. This is not just for medicine, it also is better for economics, all better for economics also, for every hospital that deploys this platform. That's where we are going forward and looking at. So the same ICU shift, but it's in a completely different world. That's what we are going to do. I'm just putting out what would eventually happen before and after. Where when I say after, I'm talking about RUCU and Centu ICU coming into picture. Today, what happens is nurse calls you, the vital gets dropped, no trend context in EMR. Eventually, there's manual entry, crisis recognized after the collapse, discharge summary has been typed at the midnight, orders, verbal handover, awake patients occupying ICU beds. That's not what we actually wanted to do. With IUICU and Senti ICU, the dashboard flags it 6 hours early, full vital trends on your screen before you pick up the phone. Voice becomes structured EMR in seconds, not even minutes. The AI alert comes 4 to 8 hours before the event. One click generates the discharge summary, digital handover with zero information loss, and the AI scores steps down readiness around the clock. And this is the shift that you are looking at, and this is starting now, and this starts now, if I actually have to say. So, what did we think? We started asking ourselves with one question. What was that question? What if the ICU could think? And I think I should with the core IICU and with Senti ICU along with Dr. Ibe's advice, it turns out the answer is the mattress that gives you DVT messages, a bed that does chest physio, an AI that tells you at midnight what is going to go wrong at 3 a.m. So that's what we are actually looking at. This is the modules that we are actually looking at. And I just put it out a sample on how the ICU patient dashboard would actually look like. For past 2 days, we've been looking at disruptive technologies being talked by different professors, Federico, Goyu, Samji, and many, Roberto, and many other. Listening to it as a third person, one thing that I actually wonder is it going to be is are we actually talking about future of medicine, or is it a plot of a very specific science fiction film directed by James Cameron? It is not definitely the science fiction, it is the former, which is the future of medicine, and we are very proud that would one of these would definitely be as part of the future of medicine itself. With that, gentlemen, thank you very much for your time. I think I was with the time given. I think I was able to put it out what future of ICU is, what it's going to look like. Thank you again.
Thank you, Raja. Thank you very much for that talk, brilliant talk. Now we would want
Dimitris.
others. Hello?
Dimitris Tolis. Yes.
Yes, please, Dimitris Tolis, please go ahead. That will be the last talk, I guess.
I think so, yes.
Yep.
Is that the last talk today?
Yes, yes, I think so.
Okay.
Okay.
Right.
So I have the honor of closing, right?
Yes.
All right. All right. So thank you very much for having me. My name is Dimitris Stolis. I come from a totally different background from all of you. I'm an expert on education and AI. And I work mainly with European Union agencies, with police, with Civil Europol, with drug prevention agencies, asylum agencies, and the United Nations. So my job up to now is, for the last 25 years, how to make education more specifically on a specific work setup, like for example, in your case, the neurosurgery and the wider care team, how to make it more transformative and to make it more motivational, because I've seen your presentations and I'm amazed that I come from education and computer science and AI. So what I saw is amazing what you're doing. My contribution, I believe, to this setting you have here is how can we use AI not directly for robotics and or for example having signals from the patients and all that nice things that we saw. My thought is how can we help all the care team learn in a better way, because you are doing what you're doing. However, the family, the patients need support, need care, need communication. You as neurosurgeons, you need some good communication with your team. You know that better than me. So this is where I come, and I have a short presentation. I know it's Friday afternoon and afternoon for Greece anyway, and the weather is excellent, so there could be many plans. So I will not take a lot of your time, and I'm going to share some ideas to show you how we can start rethinking education and academies in the medical world. This is I believe you will be able to see that as I understand. Okay, so the idea, we start with the idea that today we have two main, let's say, in generative AI, of course, we have two main worlds in education and academies, etc. Most of the people are focusing on the first block that you see here. How can I use AI to make my productivity better? How can we use AI in medical universities and academies so that we can make more content? However, the other one, the AI for learners, is not that developed. And this is our mission at Human Asset. How can we use AI to rethink about education and do things that we couldn't do for so many decades? Just to give you some ideas. Now, in e-learning, when your people are trained or you train them, we have one size fits all, meaning you give them something. If I am more advanced or not, the system does not care. I have the same thing. It's passive. You just read, you click, and you get some tests or whatever, generic quizzes. Not real world examples, simulations, not that many because simulations cost. And I cannot have so many simulations around. And limited personalization, so this takes us to lower motivation. With AI now, we have some risks very briefly and some opportunities. One is that there is an illusion. People scroll and they feel that they learn, but in fact, it's just noise in their brains. We have learners, we have teams that, okay, they scroll something and say, oh my God, I got it, I know what to do, but they don't, they have not changed. We watch videos and we say, okay, I'm ready to do it, but no, it's passive again. We save for later. I don't know if you do that. I used to do that a lot. Okay, save this article for later, save this image for later, and we never visit it again. And all these are clutter in our mind. And the worst of that happens today is that we ask AI something and we feel that we are wise. However, we are not. It's an illusion of wisdom. So we have all these problems, and some early research from MIT shows that people who are using LLMs like GPT or whatever, they cannot even remember what they did after some time when they use it for some work. Or we have this problem of overdependence. Imagine a doctor in 10 years from now cannot not being in a position to make a decision unless the AI says, okay, it's good to go. This overdependence might steal some critical skills from us or from the nurses or from the care team. And of course, the hallucinations here from your world. We ask AI, is this mushroom edible? Yes, can I eat it? And the AI says, yes, you can. And then when we are ready to die, it says, you're right, it was a poisonous mushroom, don't eat it. Or can I tell you more? So how can we trust what the AI will give us and when it guides us, when it trains us? And this is where we come in and we must do something about it. And of course, the cognitive overloading. Our brain cannot digest that many things at a specific moment. So what if we keep pouring content that we get from AI now by the thousands, articles and talks and all that? So we have all that, and of course, cheating. When we train all these people, it's very easy to cheat. We give them e-learning content, and they could very easily print screen and get results out of it. However, we have also opportunities, and this is where we focus more. The opportunities are that we can make now e-learning content and academic content for medical personnel, which can be tailored to each one, personalization. So I take this course, I get exactly based on my competencies what I need to learn and not everything that everybody gets. This is from Bloom, a very important on education researcher who said that when you're trained on one-on-one, when you have your personal coach, you learn 50% better than the traditional classroom. But how can we do it? How can we do it? Because it costs a lot. But if an AI mentor does it, that's the personalization. And also this one from Csikszentmihalyi, which is very interesting, that says that when I'm trained and when I have a certain amount of skills, let's say, and I'm trained on some challenges and I get some tough challenges, if I am low on skills and I have high-level challenges, like, for example, you've learned something, now come to apply it directly in the surgery room, now in the operations room, then I have anxiety. If I have very high skills and you give me low challenges because I'm not yet ready, you believe I'm not yet ready, I'm bored and I don't find any meaning. So the good trainer, the good educator, the good academic always tries to balance these two. But how can you balance them for each one of your trainees, of your people that you're mentoring, new surgeons that are coming, and you are their mentor. And the idea is you can give them exactly what they're needed. So personalization again. So in order to do all that, and I will take you directly on that, we can create in education today personalized and human-centered systems, which take this from Plato, since you're in Greece, and to have in mind that the mind is not a vessel that needs to be filling. It's wood that needs to be ignited so that people start thinking, make it challenging, make it for them customized and personalized. So in order to do all these, we have created a platform which also uses gamification and is very, very customizable. This, for example, here is on interviewing skills, but it can be on nursing, on how nurses can talk to families or any other skills that we might want, and it has some basic features. I don't want to tire you with that. So the idea is that you can create any course that you wish for the specific target group of your specific team when you know their challenges, their drawbacks, and you can create for them whatever you need based on a specific template. And then you doing that, you have a storytelling based, let's say, example that creates whatever we need here, a surgery room, an operations room, which gives you a scenario and you must go through some theory, some quizzes, etc. And this is very interesting because it's for the first time after 20 years or so what we've been waiting for that while AI was developing, we can have things like adaptive quizzes, meaning you have all taken quizzes in your life, in exams and in many settings, I'm sure. So always we had a set of questions we needed to answer with a predefined set of feedback in practicing and all that. Today, we have a better option. The system can feed you with questions adaptively based on your personal knowledge. So it examines your knowledge based on a competency framework. And if you struggle, it gives you easier questions. If you are good at it, it gives you more challenging ones. And you cannot stop until you succeed with all your competencies. Imagine, not just quizzes that you predefined, you get what you need in order to learn. Then you can talk, for example, with mentors like this, with coaches, and open-ended, asking you, how would you treat a patient who had this issue or that issue, and then you answer and you get open-ended feedback, and then summarizing points, etc. And the last one, too, which is one of the most interesting ones, is that you can start talking to an avatar, voice to voice, and role play situations like talking to your team, giving feedback to your care team after a difficult surgery, or talking to the family, and the system creates the scenarios and the characters, and you, the learner, must directly speak to the character and explain everything. And by the end of it, it gets of course real-time feedback here whenever you get some points to know how you are doing, and then very detailed feedback how you can improve, what you can do to make your life better. So summarizing and trying to be on time, what we can do today is that we can revolutionize our academies, our universities, the medical education with things that we educators have been waiting for decades. Now is the time to think of AI not only technically on a robotic arm, which whatever you're doing, or with your microscopes, exoscopes, and all that, which are amazing. But let's think of it as an enabler so that we can have better teams at scale, even if you have 10,000 people in, because I know in India you have huge amount of people, not like Greece, and in your teams and your hospitals and universities, we can scale it up in a way that it would be almost similar having one-to-one. And if you are willing to give your knowledge and expertise to the system so that you can inherit all your wisdom to the system, then the agents can multiply that by thousands and give it to the people who will be the next doctors that are coming, next nurses, next psychologists, next care team in your surgery, making our lives and of course your profession more safe, more interesting, and maybe even make the future of us, who are not in your profession, have better services all over the world. So this is from my end. I hope I didn't tire you with education, just on a different note of what you discussed so far. So open to any questions or comments, feel free. Okay. You can put in writing if you have any comments.
Thank you so much. And that was an apt closing statement and an apt closing talk. And thank you all very much. In many ways, this meeting was a disruption. For the first time, the WFNS Innovation Committee was meeting up in Athens. We had some setbacks, especially Vasilios to start with. It would have been very easy to cancel the whole thing and then say, yeah, we had some setbacks and we could not do it. But then what we decided was to go ahead. And it has been one of the finest meetings that I have ever attended. Thank you. Thank you, Bill. Thank you, all the brothers, starting from Guo to Afsal, to Bill, to Roberto, to Federico, to everybody who came in, attended. Thank you, Raja, Svetlana. Thank you, Sanma, Rajkumar, Ramkumar. And thank you all the people who talked. It was an absolutely amazing meeting. And I hope to host you all again in India in Jan. So till then, goodbye. See you guys. Let's keep disrupting.
Recording stopped.